Good evening, everyone, all audience in the Middle East, and good afternoon to audience in Europe and UK. Emirates Rheumatology Academy has the privilege to have another event where updates in science will be brought to everyone with the vision of the president of the ERA, Dr. Walid Shahi, and with the support from sponsors, Pfizer, and technical team from Infamed. We are bringing this event with the collaboration and of three well-known speakers internationally, and they are Professor Mundir Kamashta and Professor David De Cruz and Professor Philip Helliwell. We hope we will all benefit from such a day, and we present first Professor Mundir Kamasha, who is well known to everyone, but a summary that he has finished his study in Barcelona in Spain in medicine, and then moved to the UK and finished his MRCP and RCP by 2002. He has joined the Lupus Center in London and was there for 30 years, and he managed to establish that center as one of the famous tertiary centers, not only from UK, but from outside UK as well. And he has helped in a lot of research with the team there, and it was the lead in the research unit in St. Thomas Hospital Lupus Unit. He is served on editorial board for many journals like Clinical and Experimental Rheumatology, Lupus, and other journals, and he himself has published more than 700 peer-reviewed presentation himself. He then had sabbatical leave to move to Dubai and establish the Lupus Center or unit in the Dubai hospital, where it served the region. And on his retirement, he has moved to China to work for as an advisor for a new emerging marketing area as expert in the lupus field. He is one of the well-known figures in lupus and antiphospholipid antibodies, where his interests and all related topics. I hope I could summarize his rich CV by this paragraph and welcome Professor Kamashta for his talk.
Thank you, Atif. Can you see my slide?
Not yet.
Okay. Let's share again. Let's share again. Too many people involved. Wait just a minute. Can you see it now?
Yes.
Yes? Okay. Can you see full screen? Hello, is it full screen? Thank you. Thank you. Good afternoon, good evening. Thank you very much, Athir, for a presentation, and I'm delighted to address the group this evening and talk about the topic of my special interest. Everybody knows that. I'm passionate about antiphospholipid syndrome, and today I'm going to update you about the best treatment practice in 2020. Just to disclose again my conflict of interest, as Athir mentioned, although I work with GSK with my remit to China, but I didn't move to China. I am in United Arab Emirates, so my base is United Arab Emirates. This is my disclosure. As you know, antiphospholipid syndrome is a major syndrome now. There is no textbook in medicine that published without a chapter about antiphospholipid syndrome. It's not small print disease. This is a major disease affecting many millions of people around the world. And as you know, the characteristics of this syndrome: recurrent arterial venous thrombosis in young people usually, and in pregnant ladies. Many of them have recurrent pregnancy losses and late pregnancy complications. We discussed this briefly later on. Frequent manifestation in this syndrome, although is not currently criteria, is thrombocytopenia. About 25% of the patient have thrombocytopenia. Is a good marker when you look for it and you don't have full picture of antiphospholipid syndrome. Suspect that the patient have antiphospholipid syndrome. Levator reticularis, like you see in the slide, this is very common. Another prominent marker, not yet criteria of the syndrome, but is frequently present in the syndrome. And as you know, the syndrome could be primary or secondary. And most of the time when it's secondary is associated with SLE. And this is where, hence the title of my topic, how we manage this in SLE. What's many other manifestations of the syndrome has been described. As you know, I with David DeCruz, we spent the last 30 years working with other manifestations, especially transverse myelitis. David DeCruz is the first author in very interesting paper that we published together, where 15 patients was the first manifestation of the syndrome was transverse myelitis. And whether this is lupus and whether this is lupus-associated antiphospholipid syndrome, you end up treating both things, treating lupus and antiphospholipid syndrome with anticoagulation and immunosuppressive drugs. It's very challenging when this happens. Headaches, if we leave it this to Graham Hughes, he will tell you headache is one of the major manifestations of the syndrome. But headache is frequently found in the general population and is very difficult to associate statistically in clinical studies. Even our own studies, we couldn't prove that 100%. So it's still question mark. But for Graham Hughes, when he lectured, he always starts with headache because for him is a major manifestation. Chorea, epilepsy are these very frequent manifestation. Epilepsy is present in about 10% in patients with antiphospholipid syndrome. So don't undermine this manifestation, and sometimes could be the first manifestation of the syndrome. Cognitive disorders, heart valve disease, I have a special interest there because I did my PhD thesis working with clinical manifestation and laboratory features of the syndrome, and heart valve disease was one of the major features that I published in the Lancet in 1990, many years back, and still not feature of the syndrome as defined today, but hopefully this will change in the future. Hemolytic anemia, pulmonary hypertension, you name it. This is a just partial list of the other manifestations of the syndrome found frequently around the world. As you know, the classification criteria has been modified in 2006 the last time, but what we modified is really the laboratory criteria. We have not touched the clinical manifestation of this syndrome since the discovery of this syndrome, since the 80s, okay? And we established the first criteria in 1999, and these manifestations that I just mentioned, a plethora of them in my second slide, has not been modified, has not been included yet. And I think time is right to include these multiple criteria. And by the way, this revision of the new criteria is happening while we are talking. So hopefully by the end of this year, we are advanced phases in the new criteria to very likely include levator reticularis. It is possible we are discussing whether to include thrombocytopenia as well. As you can see, heart valve disease is very likely to be included. And what's definitely will be included, the nephropathy, the thrombotic microangiopathy, which affect the kidney, which is David DeCruz also have special interest there, and we can go into that in the discussion. So as we just mentioned, the criteria will be revised both from laboratory point of view, and this time I promise you from clinical point of view. We might add new criteria, and the advantage of the new criteria for the first time will be like endorsed by our ACR and Euler. So both associations have supported us, and they will agree to call them ACR Euler criteria when these are finished. So watch the space. New criteria are coming through very soon, towards the end of the year and perhaps early next year. So what we learned about this syndrome, we learned huge lessons about this. When I was young and beautiful many years back, I was taught that whatever happened in lupus is due to immune complex disease, and the treatment obviously has to be immunosuppression. Time have shown this is not true. really the majority of patients with large vessel disease, they don't have a lupus associated large vessel disease. What they have, antiphospholipid associated large vessel disease. And not only large vessel disease, as I mentioned before, thrombotic microangiopathy in the kidney is a frequent manifestation of this syndrome. And sometimes you have a patient labeled as lupus, antiphospholipid syndrome, and the patient start having increased proteinuria. Don't assume that this is activity in the kidney. It could be thrombotic microangiopathy in the kidney, and you burn your finger by increasing the immunosuppressive drug, adding more steroids, bulk steroids, and whether really the patient require immunosuppression. So now we understand that the syndrome, although was described originally in patients with lupus, most frequently, the majority of patients, they don't have lupus at all. They have a primary antiphospholipid syndrome. They might have recurrent miscarriages and they come to the miscarriage clinic, the combined clinic we have at St. Thomas's Hospital. Or they might have thrombotic events and no lupus at all. They go to cardiovascular unit or thrombotic unit or hematology, and they don't come to you as rheumatologists. Remember, these patients are not necessarily seen only by rheumatologists. They're seen by all, specialties, including internal medicine, including rheumatology, including nephrology, cardiology, neurology, you name it, okay? These patients are spread all over the place, and they are not infrequent. This is very likely to be antiphospholipid syndrome more frequent than lupus itself. Time will tell. We don't have very good epidemiological studies as yet. One of the frequent questions, at least my patient used to ask me, oh, I have lupus anticoagulant, what's the link with lupus? And they would dwell on that because they are confused. Not only the patient, oh, what's happened there? Is technical problem? I cannot see the slides.
Please share your slides again.
Okay. Can you see the slides? Hello.
Yeah,
Can you? Okay.
Yeah.
You tell me when you see them.
I see them. What about the background?
Everybody sees the slides? Okay. Okay. So the patient are concerned whether they will evolve into lupus. And as I mentioned, that even many doctors are confused with the term lupus anticoagulant. Lupus anticoagulant doesn't mean you have lupus. So you have to clarify to the patient. And we did studies to prove that, not only that I am telling you from my head and my experience, that small number of patients, very small number, in our experience, less than 5%, of patients with primary antiphospholipid syndrome in the long term might develop lupus. Okay, the other way around is totally different. We know from our studies and other people's studies, Michel Petri and large studies from Spain, from all around the world, that 1/3 of the patients with lupus have antiphospholipid antibodies, and 1/3 of these patients to 50%, especially in our center and Michel Petri's center, they develop antiphospholipid syndrome during follow-up. So we need to prevent this from happening. So the chance of developing antiphospholipid syndrome, if you have antiphospholipid antibodies, is very, very, very risky, high risk. So we need to treat. With what we treat, that's a different story we can discuss later. Just to show you that other series from retrospective study, this is from Angela Tincani, one of my friends in Italy. She worked in this field for all her life, since the 80s as well, like me. And as you can see in blue, I highlighted, despite therapy, two messages here. A high proportion of patients experience new thrombotic event despite treatment, and only small number with primary antiphospholipid syndrome go on to develop connective tissue disease, especially lupus. And the series was 120 patients, so it was a large number of patients with primary antiphospholipid syndrome followed up more than 20 years. So what's the risk of thrombosis? Because we need to quantify the risk to act on it. Is it high, low? So what's the risk? The risk is quite high. When you see 3-4% patient year, this is not small. And these are old studies, but all of them are consistent, whether you are a healthy man in the Healthy Men study from United States in the late 80s, early 90s, or unselected APL positive population, obstetric population from the pregnancy clinic, or systemic lupus erythematosus. So all of them have incidence rate of thrombosis 3-4% patient year. Like every year goes by, you have 3% more. This is why over 10 years, the chance of thrombosis 30 to 40%. So it's not low. We need to intervene with what medication, which drug, and so on. This is debatable, but we need to intervene. Now, how we assess the risk in APL is not only antiphospholipid antibodies and lupus cause thrombosis. You have to have full thrombophilia screen. You might have thrombophilia as well, other than phospholipid antibodies. The activity of the disease, activity of lupus, sometimes associated with thrombosis as well. We need to look for other cardiovascular risk factor, hypertension, cholesterol, and all of that. The second hit will add to the risk. The presence of APL, obviously we have, for now, we have lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein 1 antibodies that all of us we measure routinely. The strongest risk is with lupus anticoagulant. It's almost consistent in the whole literature. It's a cumbersome test. It's not easy to do. You need fresh plasma, and you need to carefully manipulate the samples and reach the plasma samples, reach the lab in very good condition and so on. But once done, and is positive, consistently and persistently positive, this is the highest risk of thrombosis. And we know now from Pengo group from Italy as well, and other working in the field, including our unit, we showed that triple positive are higher risk than double or single positive. This is the famous study by Vittorio Pengo from Italy, showing that if you have triple positive in the carriers of triple positivity, the risk of thrombosis is much higher if you have only one single antibody, like, for example, anticardiolipin antibody, compared to the normal population. So take that into account. When you see double positive, higher risk than single positive, and if you see triple positive, this is definitely high risk and need to do something about it and minimize the risk as much as you can. We try to work on this, and we are moving slowly to consider antiphospholipid antibodies as a risk factor for thrombosis, and this is why we developed the GAPS score. And the GAPS score is a score taking into account not only antiphospholipid antibodies, but it takes into account other cardiovascular risk factor like hyperlipidemia, give you 3 if you have that, arterial hypertension, give you 1 as a risk factor. Anticardiolipin antibody in our hand is very good risk factor, is 5. Anti-beta-2 glycoprotein 1 give you 4. Antiphosphatidylserine prothrombin, which is a new marker, is very likely to be added in the new criteria in the future, give you 3. And the lupus anticoagulant in our hand give you 4. If you see, the total score is around 20. So you add this, and the higher the score, the above 11, for example, is the higher risk. And we established that, and we published that, and other groups have validated this. And this group from France validated the score that we would like to use in the future. I don't want to spend time on that. And other groups as well from Japan, even in Japanese patients, they validated the score. So the score is available. So the score, are you likely to use it in clinical practice, will be ideal. But I know I work in clinic and we don't have time to do this scoring system. It will be very useful in the future for clinical trials and to monitor especially those patients for primary thrombophilaxis. If you have triple positive, you have high cholesterol, you have high blood pressure, be aware of these. And for these patients, I will do anything, okay? You need to be monitoring these patients with other than phospholipid antibodies. And also will be becoming very, very useful for potential clinical trials in the future. We have very few clinical trials, so that to identify comparing apple with apple, not apples with oranges. So to compare triple positive with triple positive, rather than comparing triple positive with somebody who have borderline cardiolipin antibodies and other risk factors. So it will be very useful, this GAP score, not because it's developed in the lupus unit at all, because we didn't have anything to assess for clinical trial, and this will be a very welcome thing for clinical trials in the future. I'll consider that as innovation. Let's put it in this way. Now, what treat with? Okay, the patient have triple positive, is lupus patients, is well controlled, take low dose steroids, take hydroxychloroquine. What else I can do? Shall I add aspirin? All of us do that. Do we have evidence that we should do that? The truth is no. Although, you know, our friends in the United States, Erkan tried to do a trial, single trial with 48 patients with aspirin versus 50 with placebo, he couldn't show difference. Patient with antiphospholipid antibodies. There is no definite evidence. Will I add aspirin in triple positive and lupus? No doubt about that. I do that. I don't have evidence for that, but this is what I do. At St. Thomas's Hospital, we were at some stage very aggressive, and we tried even to consider anticoagulation because it has been done for other conditions. And we tried a trial as well. We were given a lot of money by the societies, the British societies for research, and they gave us a huge grant to do a trial comparing low intensity warfarin versus aspirin, but we have to interrupt the trial because we couldn't recruit 1,000 patients. We wanted to recruit 1,000 patients. We recruited as about 170 patients, and we couldn't prove that giving warfarin to low intensity is superior to aspirin. So we stopped the trial. We published the paper and we stopped the trial. What I do in these patients, hydroxychloroquine and aspirin, a combination of both. If the patient taking hydroxychloroquine, I myself add aspirin, although I don't have evidence for that, but I think most of you will agree triple positive will be tricky to not treat with low dose aspirin. How I treat patients with thrombosis. Already the patient have we're okay, Athir? We're okay?
The meeting and you click on join.
Yeah. Carry on.
Carry on. Okay. So how we prevent recurrent thrombosis, as I mentioned from the beginning, one single word, define this syndrome is the word recurrent, despite treatment, okay? So the chance of recurrent thrombosis is high. So what's the treatment in the long term? Well, the best treatment, well, we established by my group in a long time ago, more than 25 years ago, and was published in New England Journal of Medicine, despite being a retrospective study, because it was the best study available at that time. And we showed high intensity anticoagulation for both venous and arterial thrombosis is to prevent recurrent thrombosis, the only way to prevent recurrent thrombosis in these patients. If you give warfarin for 6 months and you stop, you are not giving any benefit to these patients. If you give for after stroke, aspirin alone is not good enough for antiphospholipid syndrome. And if you stop anticoagulation altogether after 6 months, you do very badly. And this is very clear. So after we published the paper, we were challenged by two underpowered studies, but suggesting by hematologists, both of them, suggesting that maybe for arterial thrombosis, long-term anticoagulation with INR 3 to 4 is okay, but for venous thrombosis, long-term warfarin 2 to 3 will be more than enough. We accepted that because they were randomized controlled studies. One of them published in New England Journal of Medicine, the other one thrombosis and hemostasis from Italy. We accepted that, and this is what we practice. But definitely for arterial thrombosis, we always and still recommending long-term anticoagulation with INR 3 to 4. If the patient have already recurrent thrombosis, whether it's venous or arterial, is 3 to 4. And in this syndrome, don't stop anticoagulation. Don't say the antibody is now negative, I would like to stop anticoagulation. David De Cruz will confirm that we burn our fingers in the past. So don't stop these. And there is other people in the field showing that, yes. Look at, Piet group in France, Kakoub, now Piet retired as well. They stopped anticoagulation in a sizable number of patients. And as you can see in the slide, saying, conclusion, the risk of new thrombotic event in APS patients who stopped their anticoagulation is high, even in those who showed a long-lasting disappearance of antiphospholipid antibodies. See, there's other groups, well, not me being obsessed with this syndrome, other groups also showing that. So once you decide anticoagulate these patients, unfortunately, in 2020, still the only proof of evidence that we have in the long term you protect these patients is long-term anticoagulation. What about the new oral anticoagulant? If I don't mention that, you are going to ask me about them. There is, to the best of my knowledge, there is published randomized controlled trials. There is 2. RAP study, which I was a prominent author as well with Cohen. It was our center with David and Maria Cuadrado and other colleagues, and Cohen and David Eisenberg unit. We did only for venous thrombosis. We gave rivaroxaban 20 milligrams, and we compare that with warfarin to intensity 2 to 3 for venous thrombosis. And the follow-up was only 6 months. And we used surrogate markers in the laboratory to show that the intensity of anticoagulation as good as with warfarin, as good as in rivaroxaban. I don't have time to go into details of the study, but we concluded in our study, if your patient is keen to try rivaroxaban, it's fine, providing the patient have venous thrombosis. Few months later, Pengo in Italy decided to do a similar study with rivaroxaban 20 milligrams with 2 differences. In his study, he only included triple positive antiphospholipid antibodies, i.e. high risk, and he didn't care whether the patient have at baseline venous thrombosis or arterial thrombosis. And that was, in my view, was a big mistake. He didn't follow the international recommendation that arterial thrombosis should be treated with INR 3 to 4. So he had to interrupt the study, not himself, the data monitoring committee, because patients were taking rivaroxaban, especially in those with arterial thrombosis, they have much higher rate of recurrent thrombosis, and the trial was terminated prematurely. So I was involved in the recommendation in the Euler recommendation, and we published that in Annals Rheumatic Diseases. And what we said about rivaroxaban. Here, what we said about rivaroxaban in our recommendation, taking into account the 2 trials that I mentioned. Rivaroxaban should not be used in triple positive. We accepted that from Pengo study. And if the patient insists to use them, providing it's venous thrombosis, I have no problem, especially in those who cannot tolerate warfarin and those who have contraindication to warfarin. So it's not a big deal. We definitely agree that rivaroxaban should not be used in patients with antiphospholipid antibodies with arterial event, and based on the current data, shouldn't be used these in APS with arterial events. So definitely, okay. Now, out of the blue, in April, after I retired, went back to London. This came out by EMA in April 2019 and published in 19th of June 2019. Out of the blue, we don't know who's the hematologist who recommended that, saying don't use the new oral anticoagulant or DOACs in antiphospholipid syndrome with triple positive, whether venous or arterial or whatever, just don't use them. Obviously, we did go mad. We tried to protest, but we were advised there's no way you go against this. This is EMA, there's advisors, will be political and so on. So unfortunately, patient with antiphospholipid syndrome with triple positive, especially with triple positive, you are not, I won't say use the word allowed, but we are not recommended to use the new oral anticoagulants. The new oral anticoagulant DOACs that include apixaban, rivaroxaban. The data available mainly with rivaroxaban, but this applies to all of them: apixaban and doxaban, all of these. Okay, so remember that. So we can discuss this later. We have many patients taking these drugs happily. Just to show you another trial, because after our successful trial in venous thrombosis, we wanted to do another trial in arterial thrombosis. But I told you in our center, arterial thrombosis are treated with higher INR, 3 to 4. Therefore, rivaroxaban 20 milligrams won't be enough. So Cohen came up with the idea, why we don't give 15 milligrams twice a day in these patients and do another trial. So the trial, because of the coronavirus, is delayed, but it's going ahead. So we have special permission from the authorities in England and research committees in different hospitals to go ahead with the trial. The trial did not start yet. David will update me later if our hospital approved it or not. but about to start using rivaroxaban, but notice the dose, 15 milligrams BD, i.e. 30 milligrams daily, rather than 20 milligrams daily. The trial have not started, but watch the space. What we do with those patients who have recurrent thrombosis despite warfarin INR 3 to 4, for example. So the patient still having thrombosis. It does happen. I come across these patients. Well, add low dose aspirin. Hematologists hate that. When you anticoagulate patient with INR high intensity IR 3 to 4 and you add aspirin, the hematologists really don't like that, or clopidogrel to this. But in the antiphospholipid syndrome is an exception. In our experience, we don't have many of these, but we have some. Aspirin works. So aspirin works differently to warfarin, and by adding aspirin, you might reduce the amount of TIAs and so on, that or headaches that these patients have despite in high intensity anticoagulation. Other people will say, well, why you don't try immunosuppressive drug? In the end of the day, this is an autoimmune rheumatic disease and treatment should be immunosuppressives. So I have no data on this. In early days in the 80s, late 80s, early 90s, we treated antiphospholipid syndrome with azathioprine, cyclophosphamide, and the methotrexate. We tried all immunosuppressive drug. It doesn't prevent thrombosis, recurrent thrombosis. So, and the New England Journal of Medicine in 1995 that I published, our data doesn't show that immunosuppressive drug reduce the recurrent thrombosis rate. But hey, it's an option. Add statins. There is a lot of data now, at least laboratory data, to suggest statins is not only to reduce cholesterol. It could be added in the antiphospholipid syndrome, and you will see later even in pregnancy has been used. Hydroxychloroquine is our favorite in rheumatology, as you know, and if the patient is not taking hydroxychloroquine for whatever reason, it will be an ideal to add hydroxychloroquine, trying to prevent recurrent thrombosis. Do we use a low molecular weight heparin in the long term outside of pregnancy? We do. And this publication from my group, 2011, about 20 patients who took heparin for long term, and one of my patients or two of my patients have taken long term low molecular weight heparin for 20 years. One of them even come from Jerusalem, and the other patient live in Dubai here. She's English patient and look after her and really what friendly level and become friend of the family. She took heparin, low molecular weight heparin for the last 20 years. Treatment with rituximab is something has been used in mainly catastrophic antiphospholipid syndrome, but also has been used in regular antiphospholipid syndrome, and especially in those with recurrent thrombosis. You can consider that. Hematopoietic cell transplantation. This is very interesting. Although I don't have personal experience with that, maybe I came across in the private sector. At St. Thomas's Hospital, David will remind me if we have experience with that in the antiphospholipid syndrome. I don't remember any case. In the private sector, I saw a couple of cases, but I did systematic review when I was working with Jamal Saleh and Ahlam in our hospital. It seems it works. If you are desperate and the standard of care is not responding, we did systematic review, and it seems that you manage to control the disease and even go further. And about 73%, about 3/4 of the patient managed to stop their anticoagulation. So I have no personal experience. I will be lying to you if I tell you this is my personal experience. It is not. It is a systematic review, and this is what came out. If you are desperate in severe cases, you might consider a hematopoietic stem cell transplant. It seems the data really promising, really promising. Catastrophic APS, I don't want to spend much time on it, is a fascinating condition. Fortunately, very, very rare, extremely rare. And this, less than 1% of the population with antiphospholipid syndrome. David De Cruz will remember this case very, very well. Is a patient in the nephrology department. We work at St. Thomas's Hospital. They ranked David because the patient have renal failure, but have thrombotic, and he was in intensive care, thrombosis everywhere. And when David arrived to Guy's Hospital, the patient died, have catastrophic antiphospholipid syndrome, thrombosis everywhere, microthrombosis in the skin, in the kidney, the myocardium, and the patient died. You have to act quickly. You have to act quickly. If you don't act quickly, these patients will die. Please see in the middle of the slide, typically, this disease is microthrombotic, microangiopathy, really in the kidney, the brain, the lungs, and the skin and the joints and the tissues are involved. It can affect large vessels, but typically thrombotic microangiopathy. So it's acute onset. This is a review from Ricard Cervera, who had the database of this. It's nobody have many patients. Maybe at Dubai Hospital I have 3, 4. In London, maybe David have 10 or 15. I assisted maybe another 10, 15. So we don't have many, despite my large experience in this syndrome. Fortunately, it's rare. Is multiple vascular occlusion, less than 1 week. Organ involvement, usually kidney, lung, CNS. Usually the patient have high titer antiphospholipid antibodies. And if you look at the literature, precipitating factors are common, usually infection. The patient will tell you, before I have this thrombotic events, I have chest infection or urine infection last week. Prognosis is very poor, is improving. Now we treat better, we understand better, we act quickly, but the mortality is still high. 1/3 of the patient will die. Therapy is plasma exchange plus or minus IVIG. Rituximab has been tried. And if you have a lot of money, you can try eculizumab. It's extremely expensive, but will be ideal in this syndrome from pathogenesis point of view, because this is complement inhibitor. But it's very expensive. We are talking about $500,000 a year. The recommendations that I presented were ad hoc, but we did a systematic review again with our colleagues from United States and McMaster, and now we have guidelines. We have guidelines. It's not different what I told you just now for recommendation. We published that last year. Okay, we have guidelines of how to manage best antiphospholipid syndrome, not ad hoc. This is reviewing the literature very, very, very carefully. Thrombocytopenia is very common. I received this question, when I was working at the Dubai Hospital and St. Thomas's Hospital. I'm sure David De Cruz received this question all the time. What I do with patients who are anticoagulated and still have severe low platelet count? Well, they are frequent. 30% of the patient, 25 to 30%. Severe thrombocytopenia is rare. To go below 30, 40,000 is rare. So usually mild thrombocytopenia. Bleeding is infrequent, believe it or not. Most patients don't bleed with this, and occasionally first manifestation of APS. So many patients are labeled as ITP, and years later they develop thrombosis or develop the manifestation of the syndrome. But one important thing that you see it under the slide, thrombocytopenia does not protect patient of recurrent thrombosis. So don't panic and stop the warfarin because the patient have 70,000 of platelets. Don't do anything with that. Just keep going, okay? And this is to show you that. We proved that with Maria Jose Cuadrado about 25 years ago. We did a study comparing patient with thrombocytopenia, comparing with patient without thrombocytopenia in the context of antiphospholipid syndrome. As you can see, recurrent thrombosis was 61% versus 62%. So it does not protect against thrombosis or recurrent thrombosis. So thrombocytopenia usually is mild, unless the platelet count go below 50, don't stop anticoagulation. So what happened if platelets goes below 50,000? Treatment of choice, still steroids. It works very well. So careful monitoring and give steroids if the platelet count go below 50. If corticosteroids fail, then you have options. Low dose aspirin, believe it or not, is sticky blood. The platelets stick together and might help thrombocytopenia, which is paradoxically saying, how you give low dose aspirin to somebody who has thrombocytopenia? And the antiphospholipid syndrome work. Antimalarials, if they are not taking it, should consider that. If you really would like to increase the platelet count frequently, because you're going to intervene or you're going to deliver the lady during pregnancy, IVIG will be your treatment because you increase the platelets for a while. Immunosuppressive drug, even splenectomy. We have a large number of patients. David De Cruz will remember that. I published that in St. Thomas's Hospital. And David Eisenberg have large experience with splenectomy in these patients. It's not the first choice. It's the last of our choices. But we have a large experience with maybe 20 or 30 patients with splenectomy. And Beverly Hunt, our hematologist, have large experience with that. But I would recommend also L-Trompobag. I didn't use it at St. Thomas's Hospital because this is expensive drug. But in Dubai Hospital, and if Ahlam is on phone, she will on the call, she will remember that we used it in a few patients with severe thrombocytopenia, and the response was excellent. You give 50 milligrams daily. It's expensive drug, is available, and you can resolve thrombocytopenia. Pregnancy, I have special interest. I don't want to prolong the presentation. Remember that recurrent miscarriages, 3 consecutive recurrent early miscarriages, 10% have antiphospholipid syndrome according to current criteria. Second to third trimester loss, 20% have antiphospholipid antibodies. And if you have intrauterine growth restriction and late loss, i.e. what we call in England stillbirth, 30% will have antiphospholipid antibody, and therefore they have the syndrome. The good thing about it, once you discover that they have obstetric antiphospholipid syndrome, treatment is very good. So response is very good with more than, in our clinic, more than 85% success rate with treatment with aspirin and heparin and combination of these. I published tremendously in this, and this has not changed anything. No change, still low molecular weight heparin and aspirin, a combination of these, depending in the situation, whether the patient have thrombosis in the past or not. So it's still the treatment of choice, no change. Well, the only changes is here. What happens if you have failed with aspirin and heparin? Sometimes I try to convince my ladies to fall pregnant again, because having failed with aspirin and heparin, not necessarily aspirin and heparin failed, because you were unlucky. 1 in 5 pregnancies end up in miscarriage anyway, whether with aspirin, heparin or not, okay? Many patients, they refuse to do that. They wanted something else. My patient wants something else. And this something else could be different things, will depend where you work. St. Thomas's Hospital, we cheat. We give low dose steroids, 10 milligrams daily the first 14 weeks, added to aspirin and heparin. And we publish this in Blood, and our success rate with this regime, aspirin, low dose steroids, and low molecular weight heparin in those refractory cases is about 63%. It's not bad. IVIG, this is if we are in the United States, they give IVIG, I think because of insurance thing. Insurance might cover IVIG, I don't know why. None of the trials done with IVIG plus aspirin and heparin compared to aspirin and heparin alone showed superiority, but it's being done. Many trials ongoing currently using hydroxychloroquine in this situation. I have no issues with that. And I think hydroxychloroquine will be very useful drug to add. Plasma exchange in severe cases. I published this with our friends from Italy. In severe cases, you can consider that with thrombosis who are going through bad time during pregnancy. But most recently, statins has been used in refractory cases with success. I'm not going to dwell on that, but maybe in the discussion, I can dwell on that. Statins is labeled as X, don't use as rubbish. Don't worry about that. More than 1 million people around the world took statins because the obstetrician thought statins might prevent preeclampsia. It doesn't look that statins prevent preeclampsia, but it has been given to more than 1 million ladies around the world during pregnancy, and there is no signs of side effects. This is the EULAR recommendation. If you are interested, I am involved as well about what to do in pregnancy. You have details of that in the publication. I'm not going to dwell on it. Only to finish, and this is, David knows this slide very well, to dwell about our series with Cervera with 1,000 from the Euro APS project. We followed patients for long term, more than 10 years. And we have 1,000 patients followed for 10 years. Half of them primary antiphospholipid syndrome, and the other half SLE-associated antiphospholipid syndrome. Look what happened after 10 years of follow-up. At baseline, deep vein thrombosis 39%. After 10 years, 4%. We are treating very well. Stroke TIAs 31%, 9% after 10 years. Excellent. Pulmonary emboli, we reduced from 14% to 4%. Myocardial infarction 6% to 2%. For thrombosis, we are doing extremely well. Look about pregnancy, okay? Here is the problem. So preeclampsia remained the same, early pregnancy loss remained the same, late pregnancy loss remained the same. We improved a bit, but not change. Look at live birth with prematurity and live birth with intrauterine growth restriction, increased dramatically. That it tells you, in other words, we prevented early miscarriages, but with the treatment, with our treatment, aspirin, heparin, hydroxychloroquine, you name it, we improved the outcome of these patients. But still, many of our patients deliver prematurely. Deliver at 31 weeks is not ideal, okay? So the treatment of this condition, antiphospholipid syndrome, still not perfect. And it's your obligation as physician to tell the patient, I give you aspirin, heparin, hydroxychloroquine, whatever you want, but you have to counsel that patient there is a huge risk. We're talking about large risk that you might deliver premature baby and the baby require intensive care. I'm finishing, Athir, don't worry. The patient might require intensive care for 3 to 4 months. And that's important in the counseling, that our success rate is good. We are very good, but not good enough yet. And this is my summary slide. Clinical and laboratory classification criteria are being revised towards the end of the year. You will have that. Global APS score has now been developed and validated by other groups. Although treatment with heparin and aspirin in patient with obstetric APS has improved pregnancy outcome, it remains imperfect. We need to improve on that. Long-term anticoagulation remains the treatment of choice to prevent recurrent thrombosis. Unfortunately, this is what we have today, very likely to change in the future, but we don't have the magic bullet as yet. Thank you very much. Athir, I cannot hear you.
Sorry. Thank you very much, Professor Kamasha, for this very informative lecture and a lot of new information for us. I have many questions. I'm sure we can cover most of them in the next 15 minutes. Thank you for finishing early. We have over 400 registers for this meeting, which is very well attended. The first question comes as there are a combination of questions perhaps together. First of all, do we need to do thrombophilia screen when we have a triple APL? APS syndrome?
I will be quick. In our hand, I did a study with a Spanish group about 20 years back. They will increase the risk very slightly if you have thrombophilia, congenital thrombophilia. But I won't do it routinely, and we are not doing this routinely at St. Thomas's Hospital. This is the truth. Okay.
Right. Number two, in terms of nephropathy with particular proteinuria with APS syndrome, you mentioned the immunosuppression. What is your vision or approach toward this? And a question related to that, if you have low C4 level, do you think that is, let me say, an indication of some lupus activities as well or not?
Okay, this is very combined question. I'll try to answer quickly. The first answer to low C4 is to make sure is not congenital deficiency. Graham Hughes will tell you C4 null allele is frequently with lupus. So you will be C4 always low, nothing to do with disease activity. You have to make sure that C4 not represent congenital deficiency. This is very common, and Graham Hughes, one of the first authors in reporting that. We rely more in C3. C3 is more informative than C4. David will join us and might contribute to this, but C4 low is also as part of disease activity. I will take it more into account if double-stranded DNA high at the same time. In the context of antiphospholipid syndrome, complement, although animal models have been heavily involved in animal models, still very, very controversial in the antiphospholipid syndrome. Cohen and her group in David Eisenberg group, they're trying to link this, and New York group, as you know, Salmon group, also trying to link the complement activation to the antiphospholipid syndrome. But the truth, still we are not there, although might be involved mainly in thrombotic microangiopathy with the kidney involvement in the catastrophic antiphospholipid syndrome. And this is why I said eculizumab will be a very good target if it was cheap, but with $500,000. To the best of my knowledge, we have one patient, David DeCruz patient, with eculizumab. The patient died many years back. I don't know if you have more experience, David, and you can contribute to the discussion. We treated one courtesy of the company. Hey, don't think that at St. Thomas's Hospital we are rich and we did buy the drug. No, we courtesy of the company. David, persuaded them, look, I will give you samples of the patient. The patient consented to that, to learn more about that, but it is expensive. Now, proteinuria is a very important, and David can also, because I have special interest in this, can contribute to the discussion. I have no problem. That proteinuria, don't assume increasing proteinuria is due to lupus. It could be. It's very difficult to know. It could be, but don't assume automatically the patient have more proteinuria because I need to increase steroid immunosuppressive drug. Okay, don't assume that. And why don't assume that? Because we burn our fingers occasionally. The patient have thrombotic microangiopathy and the patient will require treatment. Now, I am not openly suggesting they have to biopsy always these patients, because David will tell you the chance of bleeding is higher in this subgroup of patients, unfortunately. And that we quantify that. If I remember well, the chance of bleeding in the general lupus patient 1 in 500.
Yeah.
Please correct me, David, if I'm wrong. And then patient with antiphospholipid syndrome 1 in 50.
Yeah.
So that chance of bleeding is there. So you have to ask yourself a very important question. Is the biopsy likely to help me to change my attitude towards treatment? If the answer to this question is no, don't biopsy. And David, please contribute here, because I know you have special interests. David, go ahead.
Can you hear me out there?
Yes.
Yes,
So
I can.
this is a real dilemma. So you're faced with a patient with lupus, with heavy proteinuria, maybe triple APL positive, not an anticoagulation. Is the proteinuria, and nearly always they have renal impairment and hypertension. Is this predominantly due to lupus? Is it due to thrombotic microangiopathy, or is it a bit of both? Now, generally, until very recently, we would biopsy these patients. But then over the years, and Munther will know this, we published this series of patients where we had one death, many nephrectomies, and many bleeding episodes. And the first thought was, is this a problem with our renal biopsy technique? The answer was not. We took all precautions in these patients. And it turned out, actually, the secret was in the renal biopsy. The patients who bled were more likely to have intimal hyperplasia, fibrous intimal hyperplasia. And to my simple mind, if you have fibrous intimal hyperplasia and you biopsy a vessel or puncture a vessel with fibrous intimal hyperplasia, it doesn't vasoconstrict. So we've reduced the number of renal biopsy we've been doing in these patients, and we just say, look, the risks are very high. We will just treat you with anticoagulation and immunosuppression. And we've not had any major events since then. Carefully, I mean, we still do biopsy them, but we choose our patients really, really carefully.
That's what I said. Choose carefully and make sure that the result of the biopsy is worthwhile, because that you are taking some risk here. You are taking some risk. Next question, Athir.
The preference of immunosuppression in these cases?
Okay, that's more complicated, because it has been suggested sirolimus. Sirolimus came out in a paper in New England Journal of Medicine about 5 years ago, in patient with working on transplant from France. And sirolimus is an interesting drug. Is used by nephrologists more than David DeCruz and myself and you. Okay, it's not something we use routinely. But I don't have experience with sirolimus. David, you would like to comment on that? Our recommendation to carry with the immunosuppressive drugs that we use, mycophenolate mofetil, is azathioprine. David, please go ahead.
So this is a very important paper from a transplant group in Paris, where they transplanted patients with APS, and they showed that patients who received sirolimus in the anti-rejection protocol did much better, fewer kidney losses. So I raced around to my renal colleagues and said, we must give sirolimus to our APS patients. They said, David, we've stopped using sirolimus. It's a horrible drug. There's lots of side effects. So I said, all right, what about tacrolimus? They said, it's not the same drug. It doesn't have the same effect. So we are still stuck. It was a very attractive idea, but I think we're still stuck.
And paradoxically, there is data to suggest sirolimus causes thrombosis. There is paradox as well. Okay. So it's an interesting question. We don't have answer. It's ongoing. Study is ongoing.
Back to thrombosis issues. One question is about first thrombosis with positive lupus anticoagulant positive. For how long you would anticoagulate, number one, and number two, if there are lupus positivity of some sort, do you change your approach or not?
Okay, there is no difference between the treatment in antiphospholipid syndrome associated with lupus or primary antiphospholipid syndrome. I forgot to say that, but there is no difference at all. So we looked into that. Other people looked into that. Whether you stop anticoagulation, I think that I presented this clearly. Don't. If you stop, both in our studies and gelatin cannon studies and PH studies that we were talking about, important groups in the field, showed that if you decide to stop anticoagulation, even if the antibody become negative, would be a mistake. So we don't recommend stopping anticoagulation. Anticoagulation, once you decide, you have to tell your patient is that's for long term. I tell you where anticoagulation has been stopped successfully with only one event. If you really have other very well-defined risk factor. For example, during pregnancy, the patient clotted during pregnancy. We'll say, well, maybe that thrombosis was antiphospholipid related, but there is trigger, was important trigger. The patient taking oral contraceptives. So these patients with venous thrombosis, if the patient after 1, 2, 3 years decided, look, I didn't have any symptoms, I would like to stop. In my view, she shouldn't. But these are the patients you might take the risk because you say, well, whether you did have the clot because venous thrombosis was because of the oral contraceptive or because of the phospholipid antibodies. You don't have the trigger anymore. Reduce the triggers and try to stop. David, do you have experience with that? Did you change your practice or anything?
I get into vigorous discussion with Beverly Hunt and Karen Breen. So there's this question about provoked versus unprovoked.
Yeah.
So if I'm faced with a patient who's had a provoked clot, okay, after
pregnancy
pregnancy surgery, but if they're triple APL positive, would I anticoagulate them long way? I would absolutely carry on with anticoagulation. I would not stop just because there was a provoked event. I think these are very high-risk patients, but these patients should be put into trials. But the trouble is those trials will never happen. So I think it's a clinical judgment. I would not stop anticoagulation. Even if it was a provoked event and they're triple APL positive, I just carry on.
Yeah, but he gave the example only lupus anticoagulant positive. David.
Yeah.
Okay. Carry on.
Yeah, two questions. I put them in one. First of all, should hydroxychloroquine be given only to moderate to severe IPS or also mild cases like in lupus, we give it to everyone? And number two, what is best immunosuppression for thrombocytopenia in particular?
Okay, the immunosuppression in thrombocytopenia is not the first choice. In thrombocytopenia, the first choice is steroids, okay? If steroid doesn't work, you might try hydroxychloroquine before. If the patient is not taking hydroxychloroquine, I try hydroxychloroquine. If I would like to use immunosuppressive drug in thrombocytopenia, I will go either mycophenolate mofetil or azathioprine, not because otherwise, because I have the two. I have more experience with David Cruz in our unit. This is the two we used. Maybe other immunosuppressive drugs more effective. I don't know. Is tacrolimus more effective? I don't know. But these are the two I would choose. Okay. So thrombocytopenia, the first choice is steroids. Other choices is immunosuppression won't be my second choice. So it will be immunosuppression my third choice. Okay. And I emphasize again, if you have access to L-Thrombopag, this is expensive tablet, but hematologists are using these all the time. Try it. I tried it, not in London. I don't know, David, if you have any experience with it, but hematologists love that, and it works. It works. It's not contraindicated in antiphospholipid syndrome.
Yeah.
Right. Last question, perhaps, because we are approaching time.
No problem.
Quickly, regard GPSS, why lupus anticoagulant have less point than ACL? On which one is
we utilize the very complicated formula. We agree. We utilize a complicated formula. Very difficult for me to explain it. Is the Savino did that. That we came that cardiolipin in our hand more strongly associated with as a risk factor than lupus anticoagulant, but still 4. So the difference between 4 and 5 is very little. So in our hand came cardiolipin stronger than lupus anticoagulant. I don't know why. The formula shows that, and we have to apply what we found in our patient. That's a good question. Good observation.
Yeah, I apologize for other people who put some questions, but
I am still online. If we have at the end more questions, you're welcome. I'm still online. Okay.
Right. We have a later session as well for discussion. All right. Now we have to move to our next speaker, Professor Philip Halliwell, who I have the honor to meet him several times, and he is a consultant rheumatologist in Leeds and University and Bradford Hospital, and who has graduated in Oxford in 1972. He worked abroad in Australia and New Zealand for a while, and then when he came back to Leeds, he worked with his predecessor, Professor Werner Wright, and then he joined ankylosing spondylitis group, as well as he became also the co-founder of the GRAPPA group, the famous GRAPPA group, this group that has established many, let me say, landmark practice points, including CASPER criteria, including treatment algorithm, including so many different things in terms of improve the management of psoriatic arthritis. He has more than 300 peer review papers, and he is instrumental in, let me say, a member of steering groups in the management of psoriatic arthritis. And that is just a brief summary to his very long and rich biography. And he has recommended me to join GRAPA, and thank you very much, Philip. And the microphone is yours.
Now.
Inflammation in the metatarsophalangeal.
Now I hear him.
Yeah.
Erodes ligamentous integrity in the foot. They'll find that their foot isn't fitting in their shoe quite as well. And so it's causing pain, pebble sensation I described to you, and also this widening. And at the rear foot, you'll see that they develop this sort of valgus deformity. And if you look on the left here, there is clearly bulging. This is because of inflammation in the tendon of tibialis posterior, which is a substantial tendon that passes around the medial malleolus of the ankle. And this causes functional posterior tendon dysfunction. But normally, if you ask someone to go on tiptoes, not only is the soleus and gastrocnemius working, but also the tibialis posterior, which stabilizes the ankle. If you didn't have that work, you went on tiptoe, or you would struggle to get on tiptoe, but your ankle would come right across like this. So it's often an interesting and useful test to do in people with rear foot pain, is to ask them to go on tiptoes and observe from the back that this that the line is straight when they try and do this. As the disease progresses, of course, more deformity will occur at the foot. There'll be flattening of the longitudinal arch because the tibialis posterior isn't working, further widening of the foot, drifting of the toes, and these hammer deformities of the toes beginning to appear. And of course, in the severe cases, well, sorry, this is still medium cases where you see the toes become non-weight bearing. So that normally, if you take a pressure print of the foot, you'll see the imprints of the toes and metatarsal heads on the heel. But in this case, the toes aren't actually touching the ground when the pressure takes the step. And you can see that here on the bottom of the foot, and the callus that's forming up at the metatarsal head to classify pressure. And in advanced disease, all these features become more pronounced. So here you have complete collapse of the the patient is walking on the navicular bone, and you see the deformities in the forefoot of advanced thought. Overriding toes as the advance comes across, and of the minor toes as well. And this really is not, this toe is no longer functional, and quite often we resort to amputation in these cases, of the toe that is, not the foot. So these are deformities we want to avoid, and we think we can at least delay these deformities. And recent studies we've done on surgical intervention over the years show that this is surgical intervention for foot deformities becoming less prevalent. So I think we are winning the war against foot deformity, and hopefully we're not going to see such severe deformities moving forward. Other things that may occur in the foot with rheumatoid arthritis are enthesitis, not confined to psoriatic arthritis, bursitis, tenosynovitis I've mentioned. Morton's neuroma-like symptoms may occur due to bursitis, intermetatarsal bursitis. We don't see a lot of rheumatoid nodules these days, but they can occur in the foot, particularly in the soft tissues and the Achilles. And of course, there are vascular and neurological associates with rheumatoid arthritis that are a related feature of the disease. So I move on to psoriatic arthritis, a particular favourite of mine. Then you have these hallmark presentations that, as well as the arthritis that we see, the enthesitis, which is such a prominent feature, and the commonest major sites are the Achilles tendon and the plantar fascia. But we've shown that there are other sites that are frequently involved, one of them being the tibialis posterior attachment to the tuberosity of the navicular and the attachment of the peroneus brevis to the base of the fifth metatarsal. And I understand when I'm talking about these bones and attachments, it may be challenging people's anatomy, but this is one of the problems with the foot and ankle, is that we do lose the anatomical structures. It becomes a bit of a black box. I'll come to that in a minute, Skin and nail changes are quite common, of course, with psoriatic arthritis. Dactylitis is a hallmark feature. And ultimately, radiological features are distinguishing, particularly such things as the pencil and cup appearance in arthritis mutans. Here are some anatomical guidelines to help us identify the enthesitis. We're talking particularly about the insertion of the Achilles on the calcaneum, plantar fascia on the calcaneum. Here we have, this is a lateral view, this is the common peroneal tendon, this peroneus brevis attaching to the base of the fifth metatarsal. And this is a common site for enthesitis in psoriatic arthritis. And on the medial side, you'll see the big tendon here of tibialis posterior, which attaches to the tuberosity of the navicula, which you can palpate in yourselves very easily, but also, of course, goes around and attaches to the metatarsal. This is an image of enthesitis, insertional enthesitis in psoriatic arthritis. I'm often referred people with problems up here, which is nothing to do with the enthesial region, is not associated with psoriatic arthritis. It is a common problem. I'll come back to that later. And dactylitis, which can stand out a mile, once you've seen it, you'll never forget it. Here in the second toe, here in the big toe, and probably over the toes. Don't forget the skin and nail changes. Here you see the hyperkeratotic dystrophic nails. The problem with the foot and nail changes is that fungal infection can often cause similar changes, but not every nail is involved to such an extent as this. But you have to be wary of fungal involvement mimicking nail psoriasis, and I think that hand is a more reliable site of nail involvement. You may see classic plaques of psoriatic psoriasis, as you can see here, particularly over the joints, as you can see here in the big toe. And an alternative presentation of psoriasis in the feet is this plantar presentation. This is almost pustular plantar, but it can also appear as a hyperkeratotic area. These are areas, if we don't look at the cells of the feet, we will miss, and the patient won't mention it to you. You're the rheumatologist, and we don't deal with skin disease, do we? So they'll never tell you unless you go looking. What about ankylosing spondylitis? Well, the foot is less commonly involved with ankylosing spondylitis, but insertional enthesopathy is certainly a feature. And mid-tarsal involvement I have seen in the past, probably not as much nowadays because of the use of TNF inhibitors, but mid-tarsal joints can cause a severe arthritis and a very distinctive gait. What about gout? Gout affects which we can get acute gout, otherwise known as podagra in the first MTP joint, which we rarely see in hospitals. This is a primary care problem that is treated in primary care usually reasonably well. What we see is the chronic gout, and particularly tophaceous gout, here obviously in the hands, but tophaceous gout can occur in the feet as well, and it usually comes to me as a late feature. This toe here was not dactylitic. This was due to gout, and we obtained calcium, we obtained uric acid crystals from a lesion in this toe. And this toe also had associated radiological changes, the so-called rat-bite erosions and bone destruction that is associated with gout. Because of the radiological change that may occur and this appearance clinically, this is often mistaken as chronic osteomyelitis, and I've had several cases referred after amputation when the penny has finally dropped that this wasn't an infection but a crystal-related disease. I'd like to talk a little bit about neuropathic joint disease because although it's rare, it's a very disabling joint disease and presents primarily in the foot, particularly the midfoot and the ankle. And it's on the increase, and it's on the increase in people who've got diabetes, not in people who've got TABIes, which it was in the past. Alcohol is another important factor. But delay and misdiagnosis is common, and the reason for that is there are delayed X-ray findings. So people may present with foot pain, but the X-ray looks normal and they're sent away again. Back they come several weeks later with essentially a destroyed joint and foot. So it's an important thing to be aware of when people are diabetic. So the people who've got long-standing diabetes with neuropathy, and they may just have a minor injury. I can remember several cases where they've just had a mild foot inversion injury, and this has been followed in a few days by pain, redness, and swelling. As I say, the X-ray will look normal. There may be some early osteopenia, but this injury progresses rapidly. So this constellation, clinical constellation, should be serving as a warning to if they present to you. And here's some images. This was a normal X-ray and a normal early MRI in neuropathic joint disease. But within very short period of time, she developed this stability in and 3 months later, you can see the extensive changes on plain X-ray. And what happens is the joint just falls apart if untreated. So what do you do? How can we treat this? Well, the clue is in early immobilization. We use an air-cat boot for this. And we use intravenous bisphosphonates. And there is some evidence now that biologics, such as anti-TNF drugs, are beneficial in some cases. But the clue is early recognition, immobilization, and as I say, we use intravenous bisphosphonates early in these cases. So I'm now going to talk about some other soft tissue disorders. Forms like back bed primary care. It's a generic term used to describe pain in the foot. And in the absence of specific findings, this is usually a functional or mechanical origin. It's like the non-specific. What about neuroma? Again, a common presentation in primary care due to neuroma, usually between the third and fourth toes. Pain is felt at the base of the toes like a pebble. The symptoms radiate into the third and fourth toes with burning and tingling. It can be quite a disabling condition people who have it. It's worse if they're wearing closed footwear. It's better if they take their shoes and socks off. Clinical findings sometimes worthwhile eliciting, which is to give this patients with these symptoms a squeeze across the metatarsals. And there is a sharp click if the neuroma is present as it's squeezed between the metatarsal heads, and of course reproduction is symptoms. And ultrasound is a very good modality for demonstrating here on the right hypoechoic area between the metatarsal heads. Studied means by orthoses, which can be bought off the shelf, will often relieve this symptom. And indeed, we inject them with steroid, the rationale which is not very clear, but seems to work very well, probably by causing atrophy in these areas. And if as a final move, we will recommend surgical excision. Here from the focal aspect of the foot. Actually, surgeons usually like to do it from the other aspect that the healing is certainly delayed. about stress fractures. Stress fractures are often caused by repetitive stress, so we see these in sports people or people who are doing other strenuous exercise or heavy physical work. Stress fracture, of course, is in contrast to other fractures, which are characterized by solid severe impact. And the thing about stress fractures is, if you take an X-ray, you quite often do not see the fracture earlier. I think you probably can see the fracture in this case. But given a few weeks later, you see the callus formation, and the fracture is obviously there. So early X-rays are not helpful in stress fracture, a bit like neuropathic joint disease, and sometimes we have to do an MRI if it's strong. And we rarely intervene surgically for these. We just offload them and treat conservatively. Plantar fasciitis is yet another common primary care presentation. And not all plantar fasciitis, of course, is due to spondyloarthropathy. In fact, the majority is caused by degenerative disease. This is always worth considering when we see patients who present like this. The plantar structure that maybe inserts into the medial tubercle of the calcaneum is protected by a fat pad, which tends to atrophy as you get older. So we're off with pain and discomfort in the plantar fascia region, worse in the morning, and aggravated on weight bearing. And if you can often locate a precise area on the medial aspect of the heel or wherever it is. And again, for degenerative plantar fascial disease, it can be very difficult to treat. But there are a number of taping, which you can see illustrated here, taping techniques and stretching techniques, which you'll see on the left, followed by anti-inflammatories and antibiotics. We do occasionally connect, but much rarer than we used to do. What we used to do is take a big needle and inject through the heel. But the recommended approach now is to come in from the side of the heel. The reason for that is if you go out with the heel, you will undoubtedly cause rupture of the plantar fascia insertion. That cures the problem that leaves the patient with a bit of a flat foot. So we recommend injecting from the side if you need to inject that. Plantar fascia may be a red flag for spondyloarthropathy, particularly if it's persistent and bilateral, and if there are no other risk factors, by which I mean obese middle-aged people with relatively fat feet to begin. So in a young man, not a sportsman, doesn't have any pre-existing foot deformity, presents with unilateral or bilateral plantar fascial pain, particularly with power Doppler and ultrasound, you're thinking spondyloarthropathy rather than degenerative plantar fasciitis. We also see a lot of ankle injuries. These are very common in the UK. People who are hypermobile or athletes, particularly if they're off-road runners or footballers or rugby players, people who wear high heels can get. The basic injury in your foot inwards. This is an inversion ankle injury. And the majority of these just leave a lot of bruising, pain, and settle in time. The quite often ATFL, the tibial ligament will be ruptured, and if the injury is more severe, you can get bony injury to the head of the tabular bone. You don't know that initially. The top athletes get MRIs after their first injury, but so the approach is to treat conservatively, and if it doesn't settle, to do further investigation. And as I say, there's a progression of ligamentous damage, rupture of the peroneus brevis, 2 osteochondral defects, which, if not treated properly, will lead to subsequent osteoarthritis at the ankle. These are typically in the tailors. So we do recommend RICE, which stands for rest, ice, compression and elevation, but not for long. Early mobilization is recommended, and that will include proprioceptive exercise. And as I said, it doesn't say that we should investigate it using imaging, ultrasound of the ligaments, or an X-ray looking for fracture, or again an MRI looking for. So let's turn to Achilles pain. I mentioned this again previously, briefly. Commonest, what we see is paracet tendinitis. We also see insertional enthesitis, which I mentioned in passing, and Haglund's before. So paratendinitis is common in athletes and elderly people. They often form a good exercise. The Achilles is thickened about 8 to 10 centimeters above the insertion. It's important to remember that. So you're looking at well above the insertion, not at the insertion in these cases. This can be caused by eruption, which is a terribly disabling problem. So you have to watch out for this in the elderly. And there are certain drugs that will predispose to rupture, steroids, of course, but fluoroquinolone antibiotics and statins can weaken tendon structures. And it may rupture also in inflammatory arthritis. This is the area we're talking about, not down here where the insertion is, but up here, where the tendon becomes thick and inflamed and very tender. Here's a case that actually appeared in the New England Journal of Medicine about an 81-year-old woman who presented with a near full thickness rupture of the Achilles week after treatment for the acute bronchitis. And obviously she had been treated with a fluoroquinolone antibiotic. That's the answer to the quiz in this question. You can see here an almost complete rupture of the Achilles tendon. What about the Haglund's deformity? Haglund's described a prominent bony spur on the posterior superior aspect of the calcanea. And this causes like a friction rub on the Achilles tendon. It's frequently associated with retrocalcaneal bursitis, and you can see changes on the in the Achilles on ultrasound and MRI. So here's what we're talking about. This is the posterior superior corner of the calcanea. You see a little bit of new bone forming scheme, this diagram, rubbing along the Achilles tendon as the heel is flexed and extended. And you can get a bursar associated with it. And you'll see here in MRI this associated inflammation at this point. Here is very nicely demonstrated, this Haglund deformity, inflammation and irritation of the Achilles. This picture is actually from a Commonwealth Games athlete that I was treating, who came along with heel pain. And he subsequently had this chopped off and it back into. For a while I used to carry this around with him because he didn't want it. And it was the size of a grape, this extra bone here. But Haglund also described extra more laterally that just cause problems with the Achilles, and these are known as pump bumps. And they're usually lateral to the insertion of the Achilles. And these cause a lot of problems, and they're called pump bumps because they're basically where shoes, particularly tight-fitting shoes at the heel, will rub against the ankle at this point. And here are some examples. This is one of the internet, this lateral new and adventitious on the lines of the ankle. see lateral to the insertion here. And here was the case I saw with this prominent Haglund deformity here and associated inflammation. These are easily treated conservatively, but then you must realise their appearance because you don't want to confuse with the insertion of enthesitis that we talked about previously. So here we are again, the insertion of enthesitis is a hallmark here, bilaterally worse on the right. It's a hallmark feature of spondyloarthropathy, particularly psoriatic arthritis and ankylosing spondylitis. And he may indeed present. The young man recently came in his late teens with an insertion of enthesitis in the heel and subsequently developed back symptoms and changes on MRI. And in psoriatic arthritis, it may present alongside dactylitis. So the patient may only present with a dactylitic toe and an enthesitic heel, nothing else. Maybe a family history, which there are something to be aware of when you're examining patients. And this enthesitis here may be associated with new bone formation. New bone formation at the heel is generally not uncommon. So you see posteriorly and inferiorly the plantar fascia in normal people. But if the new bone is fluffy, irregular margins, or has an erosion within it, this is the radiological feature that you're looking for to be associated with spondyloarthropathy. So, how do you treat the Achilles problems we've talked about? Well, for the para problem that you see further up the Achilles, there are a number of conservative interventions that we recommend, including ice and stretching, or forces to correct pronation. Some people use friction ropes or anti-inflammatory gels and anti-inflammatory tablets. What you shouldn't do is inject steroid into this area because you almost certainly cause a rupture of the Achilles tendon. There are a number of other injections that are being put in around this area, including autologous blood, dry needling, or even hypertonic saline. But the evidence for these is still rather patchy. At the end of the day, it's a big problem. You could stick the patient in an air-cast loop, and after 3 months of immobility, these things tend to have improved, although the patient's left with a very wasted calf. The insertional tendonitis, we tend to recommend orthoses to prevent any problem. Essentially, you have to treat the underlying disorder, that is psoriatic arthritis or ankylosing spondylitis. So the first line treatment is anti-inflammatory drugs. They don't work. Then disease-modifying drugs. And for years, we used to say, oh, you suck Salazine. The evidence for that is not good. In fact, the evidence for any of the conventional systemic demarkers is good. But there's been recent evidence from the BSR trial that methotrexate can help the enthesitis of psoriatic arthritis. And of course, there's good evidence for biologics, particularly TNF inhibitors, but also more recently, IL-12/23, IL-17, and IL-23 inhibitors. Now, 23 inhibitors have been suggested as the treatment of choice for major enthesitis because of the pathophysiology of enthesitis, where resident T cells that the enthesis are IL-23 responders, so they convert from resident T cells that are inactive to producing IL-17, and this is stimulated by IL-23 in mice, and probably also in humans. So the IL-23 drugs are being proposed as the treatment of choice for enthesitis and psoriatic arthritis, although, as I say, there's good evidence that other biologics work as well. In these cases, you can inject steroid, but you can't put the steroid at the insertion. For a start, it's virtually impossible to do physically. Technically, it's not good because it may cause rupture. But if you inject the retrocarpinate burst, and your friendly ultrasonographer will do this with great ease, you inject the retrocarpinate burst. This bathes the insertion of the Achilles tendon and will help the Achilles insertion and vaginitis. So finally, I'm just going to talk about multidisciplinary teams, because this is really how we and our colleagues work in the UK, or would like to work. As you can see, it doesn't happen everywhere. But the multidisciplinary team brings together different healthcare professionals in a team to support people and work out their complex needs, and each person brings their own expertise to the team. So the configuration and members of the team will vary between settings, but providing that combined expertise and chance to sit and talk about, or even with the patient, has been found valuable by both patients and health professionals alike. Do MDTs work? Well, the evidence isn't good for them. The only evidence is, of course, qualitative, not quantitative. So there's limited high-quality evidence evaluating MDT, which is a pity because it's hard to sell this to your manager. But pooled results for outpatient multidisciplinary care showed the following. And you can see here 2 studies that have been reviewed. And this plot here neither favours outpatient multidisciplinary care or the control group. One study was in favour, one was slightly against. So the evidence isn't good. And if you use an outcome like the health assessment questionnaire, it's probably even worse for multidisciplinary teams. So I think the way we're gathering the evidence isn't in most cases, because as I say, there's a lot of appreciation of the way they happen with patients and with physicians and other healthcare professionals. And in the UK, we have the NICE guidelines, of course, which recommend that all people with rheumatoid arthritis should have access to a podiatrist, and preferably within the multidisciplinary team, which should say that here, and that functional insoles and therapeutic footwear should be available. As I said, not every unit in the UK by any means has a good multidisciplinary team, and you can see here that the survey we did showed that only 17% had access to a full multidisciplinary team, and that availability was rather variable throughout the UK. So we have been doing a multidisciplinary foot and ankle clinic for many years, and we together are rheumatologists, orthotists, podiatrists, sometimes a physiotherapist and a surgeon. We only do these clinics once a month, and we only see a few patients. But the stimulus to setting them up was a high budget for footwear, orthotic footwear. And that budget we were able to halve by giving patients a proper assessment and evaluation as a multidisciplinary team. You've got to do this with adequate time and seating and to consider the problems of the patient. And you can see here from the list of diagnoses of people who were seen in that clinic, almost half were rheumatoid arthritis, and a few other diagnoses, but also we were seeing neurological diseases as well, because they have particular foot and ankle needs. So quite a wide spectrum of diseases were seen in that clinic over the last 10 or 20 years. And they work if you ensure it is truly multidisciplinary, and you give patients time. You need time, space, and seating, and you keep the patient coming back until they're satisfied currently what happens is if the patient was seen, given an orthotic and sent away again, never seen again, they will never wear that orthosis or those shoes if you provide them. Our colleagues do high-risk foot care. It's particularly true, of course, in the case of diabetes, where amputations can result from poor foot care. But in the era of biologics, it's important to keep ulcers away from our patients as well, because an infected ulcer can soon lead to a whole leg infection, cellulitis, and amputation. So the aim of working closely with podiatrists is for them to have a high-risk clinic where they can see the cases you're worried about. If you see a patient with a callus under their metatarsal heads that's already blistering and has blood in it, then you know for sure that this is going to ulcerate, and this is a high-risk case that can be managed conservatively by your podiatry and nursing colleagues. This is an important physical sign and cooperation that it will be good to foster in your clinics. I'm almost done, but I just thought I'd mention, if you have got any inkling of interest in the foot and ankle following this talk, then I would advise you to look to buy this textbook that we published just last year, an up-to-date textbook on the foot and ankle and the diseases that I've just described to you, and others, including connective tissue diseases. And this is available on Amazon and all good bookstores. So in summary, I aim to talk for about 45 minutes. I think we just about have. In summary, the foot and ankle pain are common both in the community and in rheumatology clinics. If you're going to look at the foot and ankle, the first thing is to get the shoes and socks off, of course, but then you try and be systematic. And the knowledge of anatomy and pathology is very useful at this stage. If you must use imaging, then ultrasound is usually your best friend because it's much better for soft tissue disorders in the foot. And remember that most of the treatments we use don't have a good evidence base at the moment, but there's more scope for systematic studies, and hopefully these will be fulfilled as time goes on. So thank you for your attention. I'm happy to take any questions.
Thank you very much, Professor Hollywood, for this approach in terms of anatomical description of rheumatic disorders. Can you hear me, David?
Yeah, I can hear you. And can you see my slides?
Yeah.
I'm waiting for them. Not
Yes,
yet.
I can see them. Yeah.
Yes. Let me give the introduction to Professor De Cruz, who is a consultant and professor in rheumatology in Guy's and St. Thomas Hospital, Louise Coot unit, and he is the leading team for developing that research and to establish the unit as a tertiary center for rheumatology for referral. Also, he works, his interest is translational medicine in all molecular disease, and he is leading investigator for all scientific as well as industrial studies. He is one of the key editorial in the world of lupus journal and other journals, and he has also his work translational medicine at King's College School for Medicine, and he was the president of the rheumatology section at the Royal Society for Medicine. Still remember him for giving me the prize or runner-up in Barbara Ansel prize. Thank you very much, David. The microphone is yours.
Okay. So can you see me, hear me, and see my slides?
Yes,
all
there.
there.
Yeah.
Fine. Fantastic. Okay. Well, thank you so much indeed for your kind invitation. I'm very grateful to the audience for staying up so late. I know it's quite late in the evening in in the Middle East. So my task is to speak about systemic vasculitis. Here are my disclosures. Not many are actually relevant at the moment. So here's a brief outline of my talk. I'm going to talk about GPA, MPA, eGPA, some catches for the unwary, vasculitis mimics, a brief outline on treatment, and then obviously it's very fashionable to talk about COVID, and I'll focus the flavor on vasculitis associated with COVID and virus-associated vasculitis. So these are multi-system diseases. We are all very familiar with them. They need all your powers of clinical assessment when you're assessing these patients: history, examination, thorough investigation, and relevant investigations with serology and tissue diagnosis wherever possible. So there are classification criteria. The ACR classification criteria are quite outdated now. The Chapel Hill Consensus Conference is nomenclature rather than classifications, but there are new classification criteria in process. Rashid Lukmani's leading the DC-VAS process, which is a monumental task, and some preliminary data are available for GPA, and we hope to see these publications later in the year. I think it's important for the trainees to remember that classification criteria are not diagnostic criteria. All of us as rheumatologists are aware of this, and try not to misuse classification criteria as diagnostic criteria. These are designed to be very highly specific at the cost of sensitivity, but they're quite useful, the classification criteria, because they give you all the main items to look out for when you're faced with a patient with these uncommon diseases. So this picture is shown by all vasculitis doctors, just to illustrate that this is a disease that affects all parts of the vasculature: large vessel, medium, small vessel, and the veins, particularly applicable to Behçet's. The names have changed. You're all aware of the name changes now: GPA, MPA, and eGPA. I won't talk too much about large vessel vasculitis. That's another talk in itself, in fact. There's been lots of advances in Takayasu's and GCA, but as I say, I don't really have time to cover that at the minute. So these are very obvious phenotypes. You see a patient with pulmonary nodules, you think of GPA, and then you request C-ANCA and proteinase 3 antibodies. That is quite a good association. And likewise, somebody with pulmonary hemorrhage, microscopic polyangiitis, MPA, myeloperoxidase, and P-ANCA, and then people with transient infiltrates and eGPA. In our hospital, we've stopped doing immunofluorescence. So if you ask for an ANCA test in our hospital, you will not get an immunofluorescence result, because this is probably a bit too sensitive. There are lots of false positives when ANCA testing. So now if you ask for an ANCA test, and I think this is now the case in many laboratories, you will just get proteinase 3 antibodies and myeloperoxidase antibodies back. There are genetic associations. Lyons and colleagues from Addenbrooke's showed that the genetics are mostly associated with ANCA specificity as opposed to clinical phenotypes. It's useful to group, when you're recruiting patients into clinical trials, it probably is better to recruit patients by ANCA specificity. So if you have proteinase 3 patients mainly in your trials, most of them will be GPA, but there will be some MPA patients, and you're more likely to get a homogeneous group of patients in your trial if you recruit by ANCA specificity as opposed to clinical phenotype, because there are quite a few overlaps in some of these clinical phenotypes. So the pathogenesis is unclear, but it is being worked out. This is a nice study from a nice review, actually, from David Jane's group. So I've talked about the genetics. This is being worked out now. There is some overlap between lupus genetics and ANCA vasculitis genetics. The environment is important. So there are many studies suggesting silica, infections, and drugs. So in terms of infection, we know that, for example, GPA, Staph aureus nasal carriers, are more likely to flare. And propylthiouracil is well recognized as a trigger for ANCA vasculitis. And cocaine, we have an epidemic of cocaine-induced ANCA disease in central London, and I'm sure this is the same in big metropolitan areas around the world. So we think these are the triggers. The main pathway is thought to be neutrophil activation, with secretion or excretion of PR3 and MPO antigens, which comes from the alpha granule of the neutrophils. These are recognized by ANCA antibodies, which then activate neutrophils, the release of reactive oxygen species, netosis, neutrophil extracellular trap formation, which then aggravates all that. and T cell activation, which we've done some research on T cells in ANCA vasculitis, which again contributes to the vascular damage. It's now very clear, and I'll touch on this later on, that complement is a very important pathway in the pathobiology of ANCA vasculitis, with complement activation, C5a generation in the membrane attack complex. And this is a relatively new target for treatment. So this is the end result, inflammation of small vessels, and this is what leads on to the clinical manifestations. So I'm just going to run through a few case series. Some of you, I'm sure, will have seen some of these slides before, but they're quite classic slides. So this is a middle-aged man in his late 50s, presented with a really painful red eye. You can see he's got a corneal erosion here, a corneal gutter with severe scleritis. He's got vasculitis in his lower limbs with a big vasculitic ulcer here, and he's got a foot drop on the left foot here. He had bad sinusitis with an opaque maxillary sinus. The ENT tells me that it's no point doing plain x-rays anymore, so maybe I'll take this out of my slides. You should, if you suspect sinusitis, do a CT scan, and you can see here that this is why he's got an opaque maxillary sinus. He was coughing up blood, and you can see here he's got massive cannonball lesions in his lung fields. He's got cavitating lesions. He had blood and protein in his urine, he was hypertensive, he had renal impairment, and the biopsy showed the classic necrotizing crescentic, this big epithelial crescent here, necrotizing crescentic glomerulonephritis. And of course, he was C-ANCA positive with very high levels of PR3 antibodies. So this is a classic textbook patient with generalized GPA, upper and lower airways disease, necrotizing glomerulonephritis, cutaneous vasculitis, and in this case, many other manifestations. But as with all the diseases in rheumatology, or many of them there are, this is a spectrum of diseases. So this man had severe generalized GPA with a poor prognosis if it's not treated early. But there are patients we see with localized or limited disease, first described by Carrington and Leboff in 1966, and we wrote up a little series in 1989. There's certainly some in Gary Hoffman's major series in the 1990s. So here's an example of a young lady who had nasal pain, sinusitis, blocked nose, nasal crusting, and then she collapsed to nasal bridge. Referred to the ENT surgeons where I was working at. CT scan shows opacification of the maxillary sinuses. The ENT surgeons actually made the diagnosis. She was C-ANCA positive and PR3 positive, and she had GPA. But that is all the disease she had. I assessed her very thoroughly. She had no other extra nasal manifestations at all, no renal disease, no skin manifestations. So she really was true limited GPA, ANCA positive disease. So in the old days, before ANCA, the textbook said you must have 3 features on your biopsy: necrotizing granulomatous and vasculitis with endothelial swelling. Here's a classic example of true bill textbook GPA. The problem is that if you depend only on histology, you will miss 2/3 of patients. So we did a little audit many years ago that only 1/3 of our GPA biopsies had this classic triad of necrotizing granulomatous vasculitis. So clinical judgment, ANCA, I think, is very helpful. So glomerulonephritis, you really have to be aware. In the early stages, this can be completely asymptomatic, just with proteinuria, and especially if you see proteinuria with hematuria. Hematuria is a sign that this is almost certainly glomerulonephritis. When we were based at St Thomas's Hospital, we used to send all our urine samples for urine cytology looking for cast, but now that we're at Guy's, that's not so practical. But if you do see dysmorphic red cells, which are here, and granular cast, that is highly predictive of glomerulonephritis, so it is quite a useful test if it's available. We will always do a renal biopsy, if at all possible, unless contraindicated, because it gives you a diagnosis, allows you to calculate prognosis and assess activity and damage in the renal biopsy. So the classic, obviously, is necrotizing crescentic glomerulonephritis, but we've occasionally seen patients with a really rapidly progressive glomerulonephritis going from relatively normal renal function to dialysis within weeks, and so these patients really do merit urgent attention. What about other organ involvement in GPA and in many other vascular disease? So upper airway disease in GPA is almost universal. The harder you look, the more you'll find. So I always ask patients about sinusitis, chondritis, and nasal bridge tenderness, nosebleeds, nasal crusting, loss of sense of smell. Tracheal disease in about 2/3 of patients, and lung involvement is very common. So paranasal sinus. So my practice is when in a new patient with GPA and indeed eGPA is to always do a CT scan of the sinuses and orbits. Here's a particularly florid example of a patient with GPA who had actually maxillary sinus surgery. That's why he's missing the medial sinus wall. But you can see actually it's quite affected the bone. In fact, you can see bone damage here from the inflammation and these big granulomatous lesions. So when you do imaging, about 3/4 of the patients will have abnormal sinus imaging on CT. You sometimes get surprises. Here's a patient who had only minimal diplopia, but you can see this massive granulomatous lesion in the orbit on that orbit, and you can see another patient here with these massive granulomatous masses, again GPA. In that patient was ANCA negative, which is why we went on to do, or at least the ophthalmologist did a biopsy of those orbital masses, and that gave us the diagnosis. You can see this necrotizing vasculitis in those orbital masses. So when you're ANCA negative, may be worth considering a biopsy, because there are other differential diagnoses, including IgG4 disease, which I don't have time to talk about. So upper airways disease, so tracheal disease is really worth paying attention for, because this is very insidious. Here's one of our patients who had a tracheal stenosis. And these patients can present very insidiously, very slow onset breathlessness, limitation of exercise, difficulty climbing stairs, difficulty walking. And it's my practice, at least, to do peak flows in all my patients. Whenever I see them in clinic, is to do a peak flow. So if you see a gradual decline in peak flows, be alert to this insidious onset of tracheal stenosis. So here's an example of our patients with tracheal stenosis. You can see fairly tight stenosis here, and our ENT surgeons have cauterized it, and they've used a laser here to open up the airway. Other approaches, you can, sorry, I'll just go back to that. Other approaches, with a rigid bronchoscope, you can inject the airway in the inflamed area with some hydrocortisone, which can be very helpful. So the lung is a major problem in GPA. You can get these nodules, a large nodule here, 1 or 2 little nodules here, and then cavities. So I will nearly always request a CT scan of the chest, looking to document the extent of the cavities in these patients. You can see here a man with quite bad GPA, and you can see here, in fact, this is quite a chronic cavity, and he's got an aspergilloma sitting there, and here's another one with a fluid level. Here's an unfortunate man when I was working at the Royal London Hospital with an enormous cavity which really failed to respond. This is pre-rituximab days. He failed to respond to oral cyclophosphamide and had this absolutely massive thick-walled cavity in his right upper zone. You can see other multiple nodules here. And not surprisingly, you can get complications from these huge cavities, and this poor chap had them all. He had recurrent bacterial infection. You can see a fluid level here. He had an aspergilloma, which is up there. He had hemorrhage. As the cavity expands, it can erode the bronchial vessels, and massive destruction of lung tissue. He sadly died mainly from his lung disease, even though the rest of his GPA was in remission. Vascular peripheral neuropathy is a serious complication. It's not to be dismissed. So symptoms: painful paresthesia, sensory loss, muscle weakness, and foot drop. Whenever you see this combination, this patient almost certainly has a vascular neuropathy. And my view is that these patients will always need immunosuppression. I will always do a clinical examination, assess them for sensory loss and motor loss, and I will do an EMG. So the pathology is vasculitic. So large nerves do have a blood supply, and this is vasculitis of the vasa nervorum here, leading on to axonal degeneration and leading on to, for example, foot drops and nerve palsies. So this is a nice paper. It's quite old now, but it's a very nice, beautiful anatomical drawing here from GPA, a small number of patients, but really classic paper, peroneal, tibial, ulnar, medial and radial nerve palsies in GPA. When you examine the patients, you can look at the pattern of the sensory disturbance. If you've infarcted the whole nerve, as you see here in mononeuritis multiplex, you will get individual nerve palsies, as I've shown here, median, ulnar, and lower limb neuropathies. But more often you get this asymmetrical polyneuropathy picture where you get individual bundles or individual fascicles infarcted, and that is more likely to give you this more symmetrical polyneuropathy, which is more likely what I see in clinic. Nerve biopsy, this is a tricky one. I don't do nerve biopsies anymore. You can think about doing a serial nerve biopsy, and the yield is highest when your serial nerve conduction on the EMG is absent or abnormal. The problem here is that if you do a serial nerve biopsy and you find vasculitis, you're going to treat this patient with immunosuppression and steroids. And these, in my experience anyway, maybe I've been a bit unlucky, we have had a high rate of wound infection and chronic ulcers. So I only do serial nerve biopsies when I've got absolutely no other means of making the diagnosis. The anchor's negative, they're picking off nerves, for example, in PAN, then I would work with the neurologist to do a serial nerve biopsy. The last time I did a serial nerve biopsy was over 10 years ago. So the next patient is a 60-year-old builder, presented acutely with this massive shadowing in the mid zones. He had very florid hemoptysis. You can see this extensive airspace shadowing in the lower zones. He had, again, necrotizing crescentic glomerulonephritis on the biopsy, and he was P-anchor positive. So he had classic microscopic polyangiitis, indeed, with pulmonary hemorrhage and progressive glomerulonephritis. So I've shown you the biopsy here. If you do biopsy the lungs, and it's not definitely recommended because these patients are usually quite sick, the histology is a necrotizing alveolar capillaritis. So in the old days, in the old textbooks in the 1980s, they were recommending open lung biopsies. That is extremely hazardous. We would not do that these days. Usually the diagnosis is pretty obvious. And if you do a transfer factor and the transfer factor is high, that's almost certainly the clincher. That means there's blood in the airways. And this is pulmonary hemorrhage. So these are the classic pulmonary renal vasculitic syndromes, microscopic polyangiitis and GPA, the main ones. Good pastures is not something I see, that they are seen mainly by the nephrologist. eGPA less likely to give you pulmonary hemorrhage, and these diseases even less likely to give you pulmonary hemorrhage. So what do you do with these patients with really severe diffuse alveolar hemorrhage? So here was a patient in his 70s, presented with classic GPA, very high titers of proteinase 3 and relentlessly progressive hemorrhage, not responding to treatment with steroids. They were treated obviously with antibiotics in the first instance, and he was ventilated, and you can see that even despite ventilation, he was progressing really severely. And he was transferred to our ITU, where he had ECMO. So this was quite a few years ago when the ECMO unit was established here. So this is extracorporeal membrane oxygenation. It's a very established life support technique where the machine, the ECMO machine, does the work of the lungs. It oxygenates the blood. So this is VV ECMO. VA ECMO, so venous arterial ECMO, is basically cardiopulmonary bypass. But this is a good way of providing support to the lungs and just resting the lungs. So these patients don't need intubation, they don't need ventilation. Their blood is oxygenated with the ECMO machine, and that allows you to get on with treatment of these patients. And it's a fantastic advance because it avoids this terrible ventilator-induced lung injury, which has been a major problem for decades. Okay, next patient. Here's a young woman in her 40s. Purpuric vasculitis, palpable purpura, skin biopsy showed eosinophilic vasculitis. She had pulmonary infiltrates, she had late onset asthma, and you can see that she's got a mononeuritis multiplex, right median and left ulnar nerve lesions. She had a striking eosinophilia, and she was positive P-anchor and MPO positive. So no prizes for guessing that this is a straightforward patient with eGPA, Sturge-Strauss syndrome. So she had all the features: late onset asthma, nasal polyps, a peripheral neuropathy, striking eosinophiliia, and transient pulmonary infiltrates, together with a systemic vasculitic onset of disease. So one of the depressing aspects of eGPA is that not much has changed. So these are figures from John Lanham's seminal paper in medicine, where he showed that the 5-year survival was around 62 to 65%. And the main causes of death in eGPA were myocarditis and infection. So Suzanne Lane, when she was doing her MD thesis with David Scott in Norwich, repeated this study in the 2000s and found very similar findings. So there's not been much progress, even though earlier diagnosis and immunosuppressive therapy being used earlier, we're still seeing about 2/3, sort of a third of patients dying from myocarditis infection. So it really is beholden to us to pick up myocarditis earlier. So prevalence 30 to 42%, so quite a high prevalence of myocarditis, presentations with arrhythmias, conduction disturbances, but by the time you've got to a dilated cardiomyopathy and cardiac failure, it's too late. Those patients will have a very high mortality. So we now have much better tools than we did in the 1990s. So we have cardiac MRI scan, which has been really a boon in terms of early diagnosis of myocarditis. You can see here one of our patients with late gadolinium enhancement, very clearly shown here. And the clue here is troponins. So this is our usual workup of patients with EGPA. They will get an ECG, CK, but troponin, very cheap, very easily, very widely available, has revolutionized the diagnosis of early myocarditis in our patients. BNP to assess for heart failure, echo and cardiac MRI. But the two tools that I've found the most useful are troponin and cardiac MRI scan. We've not really needed to do endomyocardial biopsy. The diagnosis is usually pretty obvious. But here's a nice picture from one of the textbooks of eosinophilic myocarditis and fibrosis. So how do we treat these patients? So this is a landmark clinical trial by Professor Wexler looking at mepolizumab for the management of EGPA. Now, IL-5 is the key cytokine in EGPA. IL-5 regulates eosinophil proliferation, maturation, and differentiation, and levels are very high in EGPA. Mepolizumab is an anti-IL-5 monoclonal antibodies, and is now a whole generation now of these anti-IL-5 monoclonal antibodies. But mepolizumab was first approved to treat severe eosinophilic asthma. So here's a trial looking at the utility of mepolizumab in EGPA. So 136 EGPA patients, phase 3 double-blind randomized controlled trial. 68 received mepolizumab every 4 weeks, 300 milligrams plus standard of care therapy with background steroids and immunosuppression versus placebo every 4 weeks. That was the study design, oral corticosteroids and tapering from week 4. So you can see this was definitely a positive study. This is participants with remission, and you can see the remission rates were significantly higher in the mepolizumab arm compared to the placebo standard of care arm in EGPA. If you look at participants with relapse, you can see that mepolizumab had definite utility in preventing relapses in EGPA patients compared to the fairly high relapse rate here in the placebo arm. So mepolizumab is clearly superior to placebo in achieving remission and a lower relapse rate, and we think this is a significant advance. There are applications now being made to the regulatory authorities in Europe, the FDA, and in Britain. EGPA, there's also been a trial in hypereosinophilic syndrome. This is not a condition I see very often. We certainly have patients with eosinophilic fasciitis, which is part of that spectrum, but that trial was also positive. So mepolizumab was also positive. The preliminary data shows positive results in hypereosinophilic syndrome. So we are making progress in the treatment of these eosinophilic diseases. Okay, so what about vasculitis mimics? So anybody in this field will have had their fingers burnt. No matter how experienced you are or how thoughtful or careful you are in your assessment, you will get your fingers burnt. So be prepared for embarrassment. So vasculitis mimics, infections are probably the most common, malignancy, especially leukemias and drugs. This is a patient, the same patient that Muntha showed with catastrophic antiphospholipid syndrome. Here was a very dramatic patient who was seen by my predecessor, who had really severe sinusitis. She collapsed a nasal bridge. She had quite a severe peripheral neuropathy and these sort of small purpuric lesions, and she ended up having a foot drop. And she was treated with cyclophosphamide, which didn't work. Not surprisingly, it didn't work because this lady did not have GPA. She was ANCA negative. She had leprosy. And when we made the diagnosis of leprosy, she actually did quite well. This was another interesting patient. I'll just move this image here. So this is a patient who's destroyed her nasal columella. She's had a massive nasal septum defect, and she was in a lot of pain. And actually, the diagnosis is on the slide here. What you can see, these little white spots here are not dust on the slide. That's the cocaine that she'd been using. So this is cocaine-induced anchor midline. So CIDML, cocaine-induced midline destructive disease. So there's lots of traps for the unwary. Here's a long list of catches, and I've been caught out by all of them over the years. Endocarditis, atrial myxoma, cholesterol emboli, cocaine. We're seeing a lot of these patients now with cocaine, and this is actually quite a difficult diagnosis to make, cocaine disease. Obviously, they're going to all deny it. My clues are, so I'm often refer these patients with just single organ disease. They've got a destroyed nasal septum, and that's it. They've got no other extra nasal disease. And the key for me is that these patients are in severe pain, much more pain than in the GPA patients. And I always ask them about cocaine. And then you have to look at their reaction. When they look a bit shifty, they've almost certainly been using cocaine. And I always ask them permission for a urine drug test. And that's paid dividends in a lot of these patients, because then if it's cocaine induced, you don't need to immunosuppress them, you don't use steroids or immunosuppressive agents. Lots of other catches for the unwary here. So what about treatment of vasculitis? So treatment, I think you really need to taper your treatment according to the patient. Tailor the treatment to the disease severity and extent. So here was this patient I showed you earlier, the young woman with a collapsed nasal bridge with PR3 antibodies. So I did not give her steroids. Oops, sorry, dear. Can I get back to my slides? Sorry, can you still see my slides?
Yes.
You can. Oh, good.
Yeah.
OK, let me go back to my slides. I can see them now. So this lady, I did not treat her with steroids. I treated her with cotrimoxazole alone, high-dose cotrimoxazole 960 BD. And you can see there's been substantial clearing of her sinus disease. The ENT surgeons rebuilt her nasal bridge, and she was very well for many years until she developed subglottic stenosis. And then I really had to treat her with methotrexate and steroids. So it is possible to treat with cotrimoxazole alone in very, very limited disease. And that came from Richard Deremy in the States, who first put this on the map. This is a randomized controlled trial in GPA patients looking at the utility of cotrimoxazole in reducing relapses. So an RCT published in the New England Journal of Medicine. So these were patients, stable patients with GPA, randomized to cotrimoxazole or placebo plus standard of care. And not surprisingly, there were fewer infections in the cotrimoxazole group, definitely fewer relapses in the cotrimoxazole group. So this is something I use routinely. It's a little bit controversial. Not everybody believes in this, but certainly for my GPA patients, I will always offer them cotrimoxazole. So assessing disease activity, there's a whole science behind this. Obviously, as rheumatologists, we're quite good at assessing disease activity. We're perhaps less good at assessing damage, but damage is really important, as I'll come back to that in a minute. And quality of life, we just ask the patient, how are you? And then we just ignore the answer. This is really important. This is the factor that is of greatest importance to patients, their quality of life, particularly fatigue in rheumatic disease. This is a big issue. So we have tools. The BVAS is the main tool for assessing disease activity. There are variations of BVAS. The vasculitis damage index is one major, the VDI, and quality of life, SF36 and the HAC. Damage is a very important concept because the more damage you accumulate, the greater your risk of dying prematurely from the disease. So damage indicates usually permanent scars like a vertebral fracture, a stroke, or a myocardial infarction. So the greater your damage index, the poorer your prognosis. Lloyd Gilvan's come up with this beautiful 5-factor score, very simple. So at presentation, if your patient is aged over 65, has significant renal impairment, has cardiac or heart failure, gut disease, especially gut vasculitis is very serious, and absence of ENT disease, this is just correlating with GPA. This is a very useful prognostic tool. So at presentation, if your 5-factor score is 0, you have a 9% chance of 5-year mortality. But if you have a 5-factor score of 2 or more, your risk of mortality rises to over 40%. So it's quite a good way of stratifying your patients and treating them more aggressively the more 5-factor scores they have. So the general treatment principles, really, in this day and age now, is we should aim or work very hard to minimize cumulative exposure to cyclophosphamide and definitely minimize exposure to corticosteroids. It's now very clear that corticosteroids can contribute severely to damage accumulation with fractures and cataracts and diabetes. So we need to move away. So you ask any registrar, how do you treat vasculitis? That's high-dose steroids. I think we're moving away from that now. There is a move now to treatment using remission, using rituximab to achieve remission and maintenance, and then move now away from oral cyclophosphamide. It's very, very rare that we'll need to use oral cyclophosphamide now, and we now use less toxic agents for non-organ threatening disease, particularly methotrexate and mycophenolate. Azathioprine to a lesser extent, but it is inferior, as I'll show you. So induction and maintenance of remission are key. So patient presenting really acutely, you need to get their disease under control with some methylprednisolone, modest doses of steroids, and start immunosuppression straight away. Once you've got the patient into remission, you need to recognize relapses very early, and that's not so easy. Easier said than done. So somebody presenting with GPA and upper airway relapse with sinusitis, nosebleeds, the question is that an infection or is it a true disease relapse of the GPA? And that can be sometimes a bit tricky. You need to have strategies for resistant disease, and as I said this already, your whole strategy here is to prevent damage and minimize mortality from the disease, and especially from your treatment. So this is the standard slide, and anybody who knows me will know that this is a hobby horse of mine and everybody else in rheumatology. So your registrar will tell you 1 milligram per kilogram per day of steroids. That is just wrong. It is a very high dose. It's traditional, it's not evidence-based, and it causes more problems than it solves. I'll come back to that. So there are various schemas. There's a massive amount of research now, clinical trials that have supported this little diagram. This is 25 years worth of research has supported this little diagram here. So once you've diagnosed AAV, you assess the disease, and then you induce remission. So somebody with severe disease, you could consider intravenous cyclophosphamide and glucocorticoids. Increasingly now, it's rituximab and glucocorticoids. For severe disease, we used to recommend plasma exchange, but that's no longer the case, and I'll explain why in a minute. So the aim is to get the patient in remission on drug, keep them in remission with maintenance therapies, azathioprine and methotrexate, or continued rituximab at fixed dose intervals, and then the ideal is to try and aim for off-drug remission, but that's very, very rare in my experience in GPA, very rare indeed. So just touching quickly on maintenance therapies. So there's been two big trials, one by Lloyd Gilvan in the New England Journal and a more recent one by Rona Smith presented at EULAR this year. The hypothesis here was that once you've got your patient in remission, either with rituximab or cyclophosphamide, can you keep them in remission by using azathioprine or repeated courses of rituximab? So the answer from these two trials is very clear. So repeated rituximab is far superior to azathioprine in terms of maintaining remission and reducing relapses. Again, these are big papers, they're very detailed papers. I don't have time to go through them in detail, but this is very much now a way forward in terms of using protocolized rituximab infusions to maintain remission. So I talked about plasma exchange. This is now the definitive trial. This is the Pexivas trial. The MEPEX trial a few years ago showed a little hint that plasma exchange might be helpful, but this is the definitive trial that shows that it is not helpful. So this is the biggest ever trial in vasculitis, over 700 patients in this trial. This is a global study that took many, many years to achieve. And this was plasma exchange versus no plasma exchange in ANCA vasculitis. And you can see that there's no difference when you look at the readout of death or end-stage kidney disease. The curves are superimposable. The other important aspect of this trial was that they also used, it was a factorial design, they used a low dose of steroids, a sort of half dose versus the standard dose. And you can see here, again, when you look at the hard outcome of death or end-stage kidney disease, the curves are superimposable. So you can use a reduced dose of corticosteroids in these patients and get the same result, but definitely minimize infections and adverse effects from the steroids. So I think this is hard evidence now that we can move away from high doses of steroids in patients, even sick patients with vasculitis with organ-threatening disease. They don't need to have massive doses of steroids. So this is the cycle we see very often in clinic, particularly with GPA patients, less so with MP, microscopic polyangiitis. So you active disease, you get them to remission, they move into relapse, and then you just keep cycling around here. And the relapses, it's quite important to classify relapses into minor, major relapses, or refractory diseases. So ANCHOR is useful. It's very useful as a diagnostic tool to help support your diagnosis. And a negative anchor doesn't exclude the diagnosis. That's quite an important point. Rising anchors often precede relapses, but they don't always predict relapses. So changing your treatment should be driven by the clinical phenotype. So new features, new pulmonary hemorrhage, new vasculitis, that should change your treatment. Do not treat a rising anchor. And there is very good randomized control evidence to show that that's not worthwhile. So there are a number of studies that show rising anchors don't always predict a relapse, and you'll be treating your patients unnecessarily if you just treated the anchor. The other important aspect is that this is in the olden days when you had induction moving on to remission. So in the old days when you treated patients with cyclophosphamide and then switched to azathioprine, if you were anchor positive at the switch, you had a higher chance of relapsing. But in this day and age, sort of induction and remission are sort of more blurred, especially if you're inducing patients with rituximab and then maintaining them with rituximab. So this becomes perhaps less relevant. So it's always important to try and predict who's going to relapse. So GPA, by a long way, the GPA patients are much more likely to relapse, especially if they are PER3 anchor positive, especially if you withdraw steroids completely in patients. Patients with ENT involvement and cardiovascular involvement, they're also more likely to relapse. And as I mentioned, the anchor positivity after completion of induction. Better renal function is more likely to be associated with relapse. That's probably because renal impairment is mildly immunosuppressive, and rising anchor I mentioned, and lower cumulative cyclophosphamide, that's now well recognized. In the old days, when we used to treat patients with oral cyclophosphamide for a year or even 2 years, they didn't relapse, but they had massive toxicity, and that was the price to pay there. So patients with vasculitis have a significant risk of dying. All-cause mortality is significantly higher here. This is Ollie Flossman's data from the UVAS trials. So these patients will have a higher rate of premature death compared to the background population by 2.6, a mortality ratio of 2.6. So the causes of death in these patients, infections, cardiovascular disease, malignancy, and then treatment-related complications. So future directions. I've always been puzzled as to why we never use hydroxychloroquine in ANCA-vasculitis. I've asked everybody, including myself, do you use hydroxychloroquine in ANCA-vasculitis? Virtually nobody does. And yet we put it in the water and give it to our patients with lupus and Sjogren's and rheumatoid arthritis. So we've got a grant from the MRC to do a trial, a randomized control trial of hydroxychloroquine versus placebo on standard of care therapy in ANCA-vasculitis. This trial is being suspended at the moment because all trials here have been suspended because of COVID, but we hope to start either later this year or early next year. So this is really exciting. I mentioned earlier about complement being a real big player in the pathobiology of ANCA-vasculitis. And avacopan is a chemocentric agent. It's highly selective oral C5a receptor inhibitor. There was a positive phase 2 trial in ANCA-vasculitis. And Peter Merkel presented this at EULAR this year. So this is quite a complicated slide. So this is the control arm. So everybody gets either rituximab or cyclophosphamide followed by azathioprine as induction and remission, and they get a tapering dose of prednisolone and avacopan matching placebo. In the active arm, they get the same, but this time they get no steroids. There's no steroids at all in this arm. They have a dummy steroid placebo, and they get avacopan 30 milligrams twice daily. And here the readouts here, sustained remission at 52 weeks and off steroids. So what was the data that presented by Peter Merkel? So this was a superiority. It was started off as a non-inferiority trial, but you can see here that avacopan is clearly superior compared to standard of care plus steroids. So really quite an exciting trial. So moving away completely from steroids with a pure complement inhibitor. what were the other data? So here you can see, I guess not surprisingly, because the avacopan arm didn't have steroids, you can see that the glucocorticoid toxicity was the readout, and you can see that worsening was much worse, obviously, in the steroid group. Improvement was better in the avacopan group. And here, not surprisingly, there was obviously less steroids in the avacopan group. So what was also interesting is that in the avacopan group, very excitingly, renal function improved. So you can see eGFR was superior, significantly superior in the avacopan group without steroids compared to the standard of care group. So this is really exciting. I think this is a major advance. So the primary endpoints, it was indeed superior at week 52. It reduced glucocorticoid usage, and it improved renal function. And it was very well tolerated. I haven't shown you that data, but it was very well tolerated. So there are recommendations which you can read yourself. So in the last few minutes, I obviously need to talk about virus-associated vasculitis. Now, these are old-fashioned diseases. We're all very familiar with them. We know that 5 or 10% of patients with polyarteritis nodosa have hepatitis B infection. Less commonly, Hep C and HIV can be associated with PAN, but HIV and Hep C in particular, is associated with cryoglobulinemic vasculitis. There is some basic science work that links in varicella zoster with GCA and aortitis, and that remains to be proven, but it's quite an exciting thought. The treatment of virus-associated vasculitis, there's been a lot of work from the French vasculitis study group, where they've initially used plasma exchange, but actually the latest studies looked at antivirals and low-dose steroids showing very good outcomes. Hepatitis C, cryoglobulinemic vasculitis, there were a couple of trials showing rituximab was helpful, but the modern approach now is these direct-acting antivirals, which I've listed on the slide here, with perhaps a small amount of steroids. So it's important to think about virus-associated vasculitis when you see patients with cryos and PAN, because the treatment is very different. You would not be giving these patients cyclophosphamide, possibly rituximab, but not cyclophosphamide. So that moves me on very nicely to COVID-19 SARS-CoV-2. Here's the structure of SARS-CoV-2, COVID-19. It's an envelope protein, membrane proteins, and the spike protein, which are all very important in how this virus gets into the system. So this is a nice diagram. SARS-CoV-2 enters the cell, often the endothelial cell, by the ACE2 receptor, the cell surface protein, in conjunction with this enzyme, TMPRSS2. It enters the cell. It then releases the RNA, which is translated into viral proteins, and then is also translated into viral replication. It uses the cell's machinery to replicate more virus particles. So this is an aerosol transmitted virus. There's a very nice video here from the New England Journal of Medicine website showing droplet spread is the key way of spreading CoV-2. So the obvious entry is through the airway. That's the most likely entry through the upper respiratory tract. But these viruses can spread throughout the body, into the lungs, obviously, where you can get lung damage. You get the inflammation and cytokine release with the cytokine storm. You can get bacterial secondary infection. You get direct damage of the lung tissue. You can get blood vessel involvement. You have viral myocarditis, and we've seen 2 patients with CoV-2 viral myocarditis in our context. Kidney disease and digestive tract. So really, this is a multi-system disease, can affect the whole body, including the nervous system. So these are some nice pictures from the New England Journal of Medicine website. So as you all know, this started in Wuhan, China, and this is how it spread. This is in March. You can see mostly in China, then Europe and the Middle East, and now, well, it's basically the whole world. The worst affected places are the USA, Europe, India, and the Far East. So as of yesterday, there have been 23 million confirmed cases of CoV-2 around the world, 250, about 250,000 new cases around the world per day, and 806,000 deaths as of yesterday. And this chart is updated every day. So what about our patients with rheumatological diseases? We're obviously very concerned when this disease came on the horizon. Are these patients going to die because they're on steroids and immunosuppressive agents? So this is quite a nice study of about 600 patients. It's a sort of registry type study published very recently in the Annals. So it shows what we know already. So if you are taking prednisolone at 10 milligrams a day or more, you have a higher odds rate of hospitalization for COV2 infection. Interestingly, anti-TNF therapies, if you happen to be on anti-TNF therapies for your rheumatic disease, you have a lower odds of hospitalization. If you're on antimalarials, non-steroidals or DMARDs, you remember there was quite a lot of controversy about non-steroidals. There doesn't seem to be any additional risk, and nor is there any protective effect, according to this paper. So just focusing on vasculitis, do we see vasculitis as part of this COVID-19? So the answer is yes. These patients very rarely, when they're really, really sick, can have a cytokine storm, and this can mimic vasculitis. Immune-mediated thrombosis is a really, really serious complication. These patients get widespread thrombosis, myocardial infarctions, strokes, basically thrombosis in the whole body, and this is inflammatory-mediated thrombosis. Cutaneous and systemic vasculitis is well described. There are a number of case reports in the literature or case series describing vasculitis as part of COV2. And then very recently, in the pediatric population, there's this Kawasaki-like syndrome, the PIMS-TS, pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2. And here at the Evelina Children's Hospital, they wrote up a small series of these patients in the Lancet. So here's a patient who was quite instructive. She was a very healthy nurse from West Africa, no previous medical problems, no comorbidities, and she developed COVID-19 and she was admitted to St. Thomas's Hospital. She had a rash, she had a high CRP, ESR, ferritin and D-dimers, all classic for COVID. Her swab test was positive for COVID. She had abdominal pain. So because of the workup of the abdominal pain, she had a CT scan which showed some stranding around the middle aorta. And so my colleague Gonya Lopez was asked to see her, and because of that abdominal pain and the perivascular stranding, she did a PET scan. And you can see here that she's got striking aortitis in the middle aorta. You can see the renal arteries lighting up and the aorta above and below the renals, and you can see it beautifully here. So this is large vessel vasculitis, definitely associated with COVID-19, and she did respond very nicely to 40 milligrams of prednisolone, tapering very quickly to stop. She did not need any other immunosuppressive or immunomodulatory therapy. So it's a real phenomenon, it does exist, and here was a classic example of a patient. So what's the pathobiology of COVID-19 associated vasculitis and vasculopathy? So we think this is an endotheliitis. I mentioned in that diagram that the virus enters endothelial cells by the ACE2 receptor and that TMPRSS molecule. So endotheliitis is probably one of the primary pathobiological factors here. Immune-mediated thrombosis is a serious complication, and there are studies ongoing as to the best way of anticoagulating these patients. Is it full-dose anticoagulation or thromboprophylaxis? There is an ongoing debate. Complement-mediated microvascular injury is well described. Post-mortem studies from Cynthia Magro, the references at the bottom there. So post-mortem studies have shown very clearly that complement-mediated microvascular injury is a feature. We have seen patients, or my colleagues have certainly seen patients with this cytokine storm or an HLH-like syndrome. It's not classic MAS, but it's very much HLH-like syndrome with very high ferritins, very high acute phase markers. And then I've mentioned the PIMS-TS, and then classic vasculitis I've already mentioned. So this is not a talk on COVID. I'm not an expert on this COVID, but I've just thought I'd highlight the very recent NIH guidelines on managing COVID. There are no approved treatments at all, no FDA approved treatments. It's basically oxygen, supportive therapy, mechanical ventilation, avoiding infection. Anticoagulation for thrombosis is a big feature, and again, there is still some controversy about how to anticoagulate these patients. So from this very current review, the recent studies suggest that dexamethasone, so if your patient is on ventilation, mechanical ventilation or supplemental oxygen, you can give dexamethasone 6 milligrams a day for up to 10 days. Where dexamethasone is not available, there are alternatives that you could use. That's basically it. there was a study that suggests that remdesivir, one of the antiviral agents, could be used for 5 days in patients who are on supplemental oxygen but who do not require ventilation. So that has shown some improved outcomes. In patients who are much sicker, needing ventilation and high flow oxygen, it's uncertain as to whether remdesivir will be helpful. Other than that, nothing else works. So there have been good studies on antimalarials, not recommended. Antimalarials plus azithromycin, not recommended, and this study had a high risk of rhythm disturbances. Other antivirals, not recommended. And insufficient data. This is a beautiful paper. It's a very long paper, but they go in detail about the evidence for these recommendations. So convalescent plasma is being used. There's a trial being done here at Guy's and in the UK using convalescent plasma, but there's no data to support its use. And none of these, they've all been used in COVID-19, but at the moment they're not formally recommended. There are case reports of tocilizumab, certainly in the HLH type disease and indeed anakinra, but there's nothing that's been formally recommended. So in summary then, Mr. Chairman, these are rare diseases, and I can't emphasize how important pattern recognition is in these patients. So when you recognize the pattern, it's obvious, but the more subtle and the limited diseases are much harder to diagnose. Autoantibody is always useful, but not completely reliable. Beware the diagnostic pitfalls that I've outlined. And we are in a very exciting area now. We're seeing, because we're understanding the biology and the pathobiology, we are seeing new therapeutic targets. And then we've now entered this even more radical era of virus-related diseases. So these are all my colleagues who've been helpful over the years, especially with these sick patients. Thank you very much for your attention.
Please unmute yourself.
Yeah.
Thank you very much, Professor, for this a very interesting and up-to-date vasculitis talk. We always learn from it. I have a couple of questions. I'll put the first two questions together.
Yeah.
One is there is a role for rituximab in EGPA?
Mm-hmm.
And secondly, would you ever use subcutaneous rituximab?
Okay, so rituximab in EGPA, yes, there is a role. There's very little evidence here. There's no big trials of rituximab in EGPA, but certainly there are patients with EGPA who are very vasculitic. So certainly those patients who are ANCA positive, so the ANCA positive EGPA patients are more likely to have renal disease, and those are the patients you would certainly consider using rituximab for those patients, and you would treat them in the same way as you would treat a GPA patient with rituximab. So I think there is a role. It's a bit evidence-free at the minute, but there's a good rationale for treating that ANCA positive EGPA patient in the same way as you would treat another ANCA vasculitis patients. Subcutaneous rituximab, I have no experience at all. I've never used it. I don't know if anybody else in the audience has. It's quite a convenient way of giving it. But on the other hand, rituximab IV 1 gram times 2 and then repeating it 6 months down the line is not that invasive.
Right. Question number 2 is more like a case description. Is a lady with or a patient with rheumatoid vasculitis.
Yeah.
Had 6 doses of cyclophosphamide, 500 milligram each. After the 6th cycle, she has resistant UTI despite repeated antibiotic courses is on the urine culture. That's only these are the details I have. So from these details, what do you make of?
Yeah. So fortunately, rheumatoid vasculitis is now very rare. I've seen maybe 2 patients in the last year, and we have a very, very big RA centre here at Guy's Hospital. So fortunately, it is much less common. But when it does occur, I find them actually very difficult to treat. These patients, the rheumatoid vasculitis, I would have a lower threshold for using cyclophosphamide in these patients. I certainly would use rituximab in the last patient. We did treat with rheumatoid vasculitis with rituximab. The problem here is the infections, the recurrent urinary tract infections, and obviously I'd refer to the urologist to find out is there another explanation for the recurrent UTIs? Has she got a little stone, or is there a bladder cancer, or something else that's causing that? But so obviously that would have to be addressed first.
Yeah, another question just came up. A patient with GPA had nasal bleed CNCA still negative, and ESR mildly raised, would you give rituximab considering it as relapse?
Okay, so I mentioned that in the talk. These are really, really difficult patients. So you've got a patient who has got GPA, generalized disease, gone into remission with whatever, cyclophosphamide or rituximab. They're now down the line. They may be on azathioprine, and they've come back now with sinusitis, nosebleeds. So the question here, is this a chronic infection? Or is it a relapse of the GPA? So I think I just take the history, examine the patient. If there are other factors, for example, they've got scleritis or they've got cutaneous manifestations, then you're more likely to treat that as a flare of the GPA. Just isolated disease, I would always ask the ENT doctors to see them, to do a nasendoscopy, and if in doubt, to do a biopsy. Because that will help you distinguish infection from active GPA flare-up. As I say, I put nearly all these patients, I put them on cotrimoxazole. Those patients, if they're on nothing else, let's say they're in remission and they just want a bit of steroids, I have a low threshold for using methotrexate for those patients with limited GPA, if they've not had methotrexate before.
Right. So
I probably wouldn't use rituximab just for limited sinonasal disease, unless it was destructive. If it was very destructive disease, then sure, I'd discuss rituximab.
okay, these are the questions I have. Just a thought. What do you do if you have, although doesn't happen often, but I have 2 cases I remember they had reaction to rituximab.
Yeah.
You just worry what to do, I mean, to give it anymore, so you have to do something else.
Yeah. So that's true. We do face this occasionally. You know, we've had one patient with a serum sickness reaction to rituximab, and another had an anaphylactic reaction. Sometimes it's not always the rituximab. We are very lucky here. We have a very big drug allergy clinic, and we've asked our drug allergy clinic to do a drug test with rituximab. And 1 out of the 2 patients, it was not the rituximab, it was the other drugs we give to prevent reactions and things. So we were able to treat that patient again with rituximab, but avoiding the other drugs.
Oh.
What alternatives? So actually, belimumab is an alternative. So there was a small study showing that belimumab may be helpful in GPA. The problem is it's not licensed for GPA, but maybe bigger studies are around. Avacopan is exceedingly promising. But otherwise, you're stuck. I'm assuming the reason you're using rituximab is you failed everything else, the methotrexate, the cyclophosphamide, and everything else. Yeah, so they're quite difficult patients.
David, what about humanized rituximab? As you know, rituximab is a chimeric. It's available, but expensive.
Yeah. Correct. So that's always available. So there are small case reports, certainly from the Hammersmith, obinutuzumab, and other fully human monoclonal antibodies.
Yes.
If you can get them, absolutely. And that's certainly, as you know, that there's been used in lupus patients where they've had reactions to rituximab. Yeah.
Because rituximab is a chimeric, you know, it's 25% from rats.
Correct. Absolutely correct. Yeah.
2 more questions just came. One is any role for mepolizumab as a maintenance therapy? What is the best maintenance therapy in EGPA?
So actually, it is a maintenance therapy. So that trial was a maintenance trial. So the patients who went in, the EGPA patients who went into that, the MIRROR trial, were induced with standard therapy, rituximab or cyclophosphamide, mostly cyclophosphamide and azathioprine, and they were then randomized to mepolizumab or placebo. So that was a maintenance study, and it showed very clearly that it was helpful in maintaining remission, preventing relapses. The trouble is it was a year study. The question is, how long can you keep going for? The data from asthma is quite promising. You can continue mepolizumab long term without any major adverse effects. But I'm not an asthma doctor, so I wouldn't be able to comment on that.
One audience said, what is the response of lung nodules to rituximab? He say he has patients who responds well in general terms, but lung nodules persist.
Yeah. So that's quite an important point, actually. So the vasculitic manifestations of ANCA vasculitis respond very nicely to rituximab, but the more granulomatous lesions, they do respond, but they take longer. So those big nodules that I showed you in the lungs, and especially I've seen a number of patients with orbital granulomas in whom we've treated with rituximab, they do respond, but they take a lot longer. You have to be patient.
I fear what happened with Philip. Philip is still, he's online.
Yeah, Philip, we just passed a question two questions, and he answered them two together.
Oh, okay, fair enough.
I'll mention the questions and the answer at the end of the session.
Yeah.
Do we have time for 1-2 more questions, or?
Sure. Yeah, I think we're quite ahead of time actually.
The last two questions, which is how would you taper steroid in ANCA vasculitis over 6 months if they are taking rituximab?
Yeah, so that's quite an important point. So I think from the Pexivas trial, those patients on average received 30 milligrams of prednisolone, and by 6 months, I think they were down to 5 milligrams of prednisolone. So I think that would be the Pexivas data, I think, is very solid, and that gives us some guidance on how to taper steroids in these patients who are obviously very sick, needing lots of steroids. So there are some guidelines from the Pexivas trial on tapering steroids without causing harm. Should we stop steroids altogether? That's a very hard question. I'm a little bit anxious about stopping steroids altogether. By nature, the Pexivas trial was only a short-term trial. There's a very nice little audit that David Jane and Mike Walsh did many years ago, and he surveyed ANCA vasculitis doctors in the US and ANCA vasculitis doctors in Europe. The European doctors never stopped steroids. They left them on 5 or 2.5 milligrams of prednisolone long-term. The US doctors, on the whole, tried to stop steroids completely. And this is very soft data, it's retrospective data, but the relapse rate was clearly higher in the patients who came off steroids altogether. And then just drawing analogy to the lupus paper, the very nice study from the Paris group in lupus patients who are completely in remission on 5 milligrams of prednisolone, randomized by Zahir Amora and his team to stop prednisolone and replace with hydrocortisone or carry on 5 milligrams of prednisolone. The patients who stopped steroids had a significantly higher rate of relapse in the lupus population. So it's very hard to recommend continuing steroids because of all the harm they do, but there may be a price to pay, and maybe the upside is maintaining remission.
Remember, Graham, he was usually leave even sometimes 1 to 2 milligrams.
Exactly.
And he will tell you,
right.
don't stop it. Don't stop it, even if it's placebo. He doesn't think it's placebo. He thinks some patients are sensitive to steroids, and 1 to 2 milligrams is more than enough. And even sometimes he does 2 milligrams alternate days.
Yes, indeed. He, as always, Graham has taught us a hell of a lot, Munter, and he was absolutely spot on. I think 1 milligram of prednisolone doesn't sound like a lot, but it is very effective.
And you stop it, and the patient flare.
Absolutely.
Whether psychological or it's but
no, it's real. I'll tell you the story about this lawyer. You remember this lady?
It's real.
Yeah. This is a lady with really bad lupus, ITU admissions and all the rest of it. We got her through all that. This is the pre-rituximab days. She was on 1 milligram of prednisolone. She said, "Doc, can't I stop 1 milligram of prednisolone?" I said, "I'm not very keen on doing that," but she did anyway. 2 months later, she was back on the intensive care unit. So, I've learned my lesson.
Graham Hughes will tell you, I told you that.
I told you so. Yes, I told you so. Yeah.
Perhaps this is the last scenario of all, and then I mentioned Professor Halliwell one. I have this comment. I have a patient with SCL70 plus scleroderma long-standing on MMF, developed P-ANCA and MPO with renal vasculitis on MMF. Would you prefer rituximab over cyclophosphamide? So this is a hypothetical scenario, or maybe a real case there, but a lot of details.
Just say again, Nasir, what was the scenario again? Yes. The renal vasculitis.
Yeah, I have a patient with SCL70 positive.
SCL70, right.
Scleroderma long-standing on MMF, developed P-ANCA and MPO with renal vasculitis. Already on MMF. Would you prefer rituximab over cyclophosphamide?
The RAVE studies and the rituximab study show that rituximab and cyclophosphamide were equivalent, at least in ANCA vasculitis. So it's basically your call. And you take in other factors. If it's a young woman, one would try and avoid cyclophosphamide and prefer rituximab. But those trials showed equivalence, at least in the world of ANCA vasculitis. Myself, I probably would go with the urolupus cyclophosphamide if it's a sort of rapidly progressive. But the data suggests you could use either rituximab or cyclophosphamide, sure.
Just for the audience, one question or two questions addressed, but one answer from Professor Halliwell about the calcaneal spurs in general. How do we know if they are mechanical or inflammatory? The answer is as a brief, if they are showing erosions or if they are fluffy bony changes or ultrasound Doppler high. Otherwise, they could become unseen here or there. So this is his answer, and we'd like to thank Professor Halliwell as well. Now we are coming to the end of our 3 hours. They just passed quickly. All science, very, very high quality science. I don't know how to thank our professor here for their time and putting efforts, putting the slide and information together. It is much appreciated, and thanks all the audience who spend their time to attend here. And we hope we repeat that at some point in the future. And thank you all, and we are happy to take any feedback from the audience in a question and answer. Thank you very much.
Great. Thank you, Athir. It was a good session. Very enjoyable.
Night.
Thank you very much.
Good night, Athir. Thank you. Thank you,
Yeah.
David.
Yeah, thank you, Munther. Good to see you.
Take care. And you. Take care, friend.
It's late there.
No problem.
Yeah.
Yeah. Thank you both. Appreciate it.
Yeah.
Take care, Athir. Take care.
Yeah. Fantastic.
Thanks.
Great stuff. Okay. All the best.
Yeah. Okay. How we leave this one? Yeah. I think we just leave it this way. I think.
Maya remain in the